Good evening and a good day to all my colleagues from other different time zones. I thank you all for joining us here today, and I welcome you on behalf of Shankar Nethralaya to the Electrophysiology Masterclass 2021. To some of you who are not familiar with Shankar Nethralaya, I'll just say a few words. Shankar Nethralaya was founded as an ophthalmic center in 1978, and ever since then, I'm proud to say that it has been consistently amongst the best ophthalmic centers in the country. We are a group of more than 100 ophthalmic consultants who are providing eye care to those in need and even those who cannot afford it. So with that, I have the privilege to invite Dr. Girish Rao, who is the president of Shankar Nethralaya, to say a few words before we start on our journey of learning electrophysiology. Over to you, Dr. Girish.
Thank you, Parveen. Good day, friends. Electrophysiology is an extremely useful tool to study the retinal functions objectively. It assesses the functional aspect of not only the retina, but also the visual pathway as a whole. Even in this era of advanced imaging, one cannot ignore the importance of functional aspects of the cellular network in the retina. Visual electrodiagnostic testing can play a pivotal role in the management of many retinal, choroidal, and optic nerve diseases, which are caused by maldevelopments, hereditary defects, toxicity, metabolic disorders, retinal vascular abnormalities, degenerative, inflammatory, and even immune-related etiologies. As Parveen said, Shankar Nethralaya has been at the forefront of integrating state-of-art technology with a set of skilled clinicians to deliver tertiary eye care of the highest quality for the past 4 decades. Be it the various or the present day diagnosis, we have made available the latest technology at both our centers in Chennai and Kolkata for the benefit of our patients. And we have had numerous publications and thesis submissions using these technologies. We have seen the evolution of testing strategies from full-field ERGs to MF ERGs to pattern ERGs to photopic negative responses, even in the VEPs, whether be it the flash, the pattern, or the multifocal, and the EOGs. This has helped us in not only the diagnosis of an ocular condition, but also in monitoring the disease progression and even the response to treatment. I'm sure this Masterclass 2021 will re-emphasize the importance of electrophysiology in ophthalmology. So my best wishes for a sumptuous academic feast. Thank you.
Thank you, Dr. Girish, for your very kind words. And over to Dr. Rupak Roy now. He's a senior consultant in the vitreoretina department and a very talented vitreoretina specialist and surgeon himself. He's from our SN Calcutta branch, and he will take us over to the first session. Over to you, Rupak.
Thank you, Dr. Parveen. We'll start the talk straight away. I invite Dr. Parveen Sen, a senior consultant at Shankar Nethralaya, Chennai, to give a talk on physiology and clinical applications of full-field ERG. All yours, madam.
Natalie, will you put up my video recording? I think it's with you. Good evening, everyone. I start today's session with my talk on the physiology and clinical application of full-field ERG. Full-field ERG is the most common electrophysiological test which is done to diagnose inherited retinal disorders, and the cellular origin of various electrophysiological tests is different. We need to just recap a little on the anatomical basis of ERG. Rods account for nearly 95% of photoreceptors and 5% cones, which are largely densely packed up in the fovea. And ERG is a mass response from the cones and rods and their neural pathways. The second order neuron are the bipolar cells with the rod synapsing onto the on bipolar cells only and the cone synapse onto the on bipolar cells as well as the off bipolar cells. In the dark, there is inward movement of the sodium, which keeps the photoreceptors at minus 40 millivolt. As the light strikes onto the photoreceptors, the cyclic GMP gated channels close, and this inward movement of sodium stops, resulting in hyperpolarization of the photoreceptors. And there is this presence of the downward movement of the A wave, which is suggestive of the photoreceptor hyperpolarization. With this hyperpolarization, the neurotransmitter release stops, resulting in depolarization of the bipolar cells with which an upward movement of the B wave. The ISCEV recommends recording of at least 6 of these waveforms whenever an ERG is done, going to each one of them one by one. So dark adapted 0.01 ERG is recorded 20 minutes after dark adaptation. It has no A wave because of very few hyperpolarizing photoreceptors at this low level of stimulus. And then we have the B wave, which is present due to amplification. So this is largely a rod-driven response of the on-bipolar cells. The dark adapted 3.0 ERG is a response to brighter light flash under scotopic conditions. There is large A wave and large B wave, and contributions from both rod and cone systems are seen under dark adapted condition, but it is rod dominated. Dark adapted 10.0 ERG is a new addition with larger A waves with better definition of peak time and greater distinction of negative ERG. Enhanced oscillatory potentials are seen, and this waveform is more reliable response in patients with opaque media or immature retina. This diagram shows the difference between a 10.0 ERG with well demarcated A wave and 3.0 ERG, which may have double peak and difficult to mark the peak time. Oscillatory potentials are seen in form of 3 waves, sometimes a 4th one, on the ascending limb of the B wave and can be seen separately as well. Light adapted 3.0 ERG is a response to flash after 10 minutes of light adaptation, smaller A waves and B waves as compared to the scotopic response, and predominantly cones and cone on and off bipolar cells are represented here. The light adapted 30 Hz flicker is more of a pure cone response due to poor resolution of the rod system at the stimulus of 30 Hz. And in addition, ERG interpretation also involves the measurement of amplitudes and peak times. And this is in the diagram, it is shown how they are recorded. In general, a decrease in amplitude reflects the underlying cell death, and a delay or in time or delay in implicit time signifies a dysfunction of the cell. With this, we come to some case studies where ERG has been found to be useful. To begin with, night blindness is one of the most common symptoms that the patients come to us with inherited retinal disorders. If night blindness is seen in patient with a normal fundus with a negative ERG in 3.0 scotopic ERG with the almost complete absence of B wave in 0.01 ERG and a squared kind of A wave with sharply rising B wave in the photopic responses, this is suggestive of CSNB. Flattened ERG with bony spicule pigmentation suggestive of RP. Typical tapetal reflex with subnormal rod responses in scotopic 3.0 ERG and normal photopic responses signifies Aguchi's disease and fundus albipunctatus. Keep it in mind whenever you see those white dots with subnormal rod responses and near normal photopic responses, and the subnormal scotopic responses increase on dark adaptation. So if you see these white dots with a normal ERG, the diagnosis is benign fleck retina syndrome. And if it is seen with extinguished ERG, the diagnosis is retinitis punctata albicans. In this case, these are two examples of two different diseases. Both the patients have a whitish deposits on the retina. ERG is not giving any answers because both of them, it's almost near normal. But here, the fundus fluorescein angiography shows well-defined areas of RP atrophy suggestive of lattice crystalline dystrophy, and flex, which are more suggestive of fundus flavomaculatus. Another example, two different patients with near normal looking fundus and yellowish flecks in one of them on the left, and normal ERG suggestive of Stargardt's disease, and on the right, which with temporal pallor and mildly attenuated vessels with subnormal rod response as well as the cone response in scotopic and photopic ERG suggestive of cone rod dystrophy. CSNB is a genetically as well as phenotypically heterogeneous disease, and ERG is crucial for precise diagnosis and functional phenotyping. The various forms of CSNB will be discussed in the subsequent talks. Just to leave you with two examples of contrasting forms of CSNB, one on the left with myopia with a negative form of ERG typical of complete CSNB, the one on the right is of a patient with with night blindness but no myopia and a Riggs phenotype of ERG. And very rightly so, the underlying mutation seen in that on the right patient is TRPM1 and in the left as SLC24A1. Two other conditions I will just mention here, which have pathognomic ERGs, and one of them is enhanced S-cone. Here, the scotopic 3.0 ERG is almost similar to the photopic 3.0 ERG, and here the mutation is in NR2E3. Cone rod dystrophy with supernormal scotopic responses have subnormal photopic responses with flattened or squared out A wave and with or without supernormal scotopic responses, and the underlying mutation is in KCNB2. So we have seen here how ERG can help us in various aspects of management of IRDs, and I conclude my talk here with acknowledgement to my VR team in Shankar Nethralaya, electrophysiological team who have been tirelessly doing electrophysiology and ER tests for several decades now, and my supporters of BioMedix and Diagnosys, without whose help this webinar would not have been possible. Thank you. Thank you for the patient listening. I have finished with my talk. Maybe we can go on to the next one.
Hello there, it's Tony Robson here. Can you see my slide in slide view?
Yes, Dr. Tony, we can see your slide.
This is in the presenter view, sir.
Okay, great. So, as Dr. Sen has eloquently explained, the photopic 30 Hz flicker and single flash cone ERGs, they arise mainly in the bipolar cells, but driven by the cones. The dim flash rod ERG is selective for the rod system. It arises in the rod bipolars, but is driven by the rod photoreceptors. The stronger flash ERGs are dominated by the rod system in healthy individuals. The A wave mainly reflecting rod hyperpolarization, and the B wave the activity of the rod bipolar cells. But important to remember, it's a mixed rod and cone system response with a small cone system contribution to this response, and that can be problematic. Just imagine you have a patient where the strong flash ERG is severely abnormal. Where is that residual activity coming from? Is it what's left of the rod system, or is it the dark adapted cone system contribution? The dark adapted red flash ERG can be useful in that situation because within the same waveform, there's a dark adapted cone mediated X wave and a rod system mediated B wave. So you can assess the relative contributions of the cone and rod systems. Also very useful in patients who are photophobic, for example with cone dystrophy, who might find standard light adapted testing more difficult to tolerate. This is a dim flash. It's usually much better tolerated by photophobic patients. And also it establishes some diagnoses. So I'll show an example. A 36-year-old woman with a long history of night blindness. The fundi and fundus autofluorescence was normal. So can you see the laser pointer? The dim flash rod ERGs from the right and left eye of the patient are undetectable. Compare these with this representative normal example. There is severe rod system dysfunction. Consistent with that, the dark adapted red flash ERG B wave is undetectable, but the X wave preserved. The important feature in the strong flash ERG is that the A wave is severely reduced, so we can localize dysfunction to the level of the rod photoreceptors. But can you see how the B wave is of short peak time compared to this healthy individual, and there's a low B to A ratio? And this waveform is perhaps qualitatively similar to the X wave in the red flash ERG. The light adapted ERGs are normal. There is no evidence of generalized cone system dysfunction. So this is severe selective rod photoreceptor dysfunction. And this strong flash ERG likely represents the dark adapted cone system contribution to this mixed rod and cone system response, but in the absence of any rod function. So what would cause severe selective rod photoreceptor dysfunction? What would you include in the differential diagnosis? Well, this is rather similar to what you see in vitamin A deficiency. After a standard 20-minute period of dark adaptation, the ERGs in fundus albipunctatus and Aguchi disease can look very similar to this, and also it can occur in autosomal dominant Riggs type CSMB. So this patient had no history compatible with vitamin A deficiency. The fundi were normal. It largely excludes fundus albipunctatus and Aguchi disease. And in fact, there was a dominant family history. And this was actually Riggs type CSMB. In this family, due to mutation, this specific mutation in the rhodopsin gene. So quite a rare disorder, but just to illustrate, one example of where the red flash ERG can be useful. Riggs type CSMB, dominant inheritance associated with variants or mutations in one of these 3 genes. Okay, a 24-year-old woman with lifelong poor vision, poor color vision, photophobia, and nystagmus. The dim flash rod ERGs in this patient are within the reference range. There's no evidence of a loss in rod system sensitivity. But can you see it in the red flash ERG, the X wave is absent, but the B wave is preserved, again consistent with the dim flash rod ERG. The strong flash ERG A wave is reduced, but only by about 20%. And the light adapted ERG is virtually undetectable. So electrophysiologically, this is almost the opposite of the last case. This looks like a functionally rod isolated retina. And we lose some of the dark adapted 10 ERG A wave because we've lost the dark adapted cone system contribution and we've lost the X wave. Findings typical of achromatopsia. And of course, very important to make this diagnosis now that there's clinical trials for the common forms of this disorder. Okay, the ISCEV Extended Protocol for the photopic on-off ERG was published just a couple of years ago. Now, this technique depends on the use of a long duration light stimulus, typically 150 to 200 milliseconds. And at stimulus onset, there's a B wave that arises mainly in the on bipolar cells, and a D wave, which is shaped by the hyperpolarizing off bipolar cells. So you can use this type of ERG to look at different post-receptoral cone system pathways. So consider this patient: lifelong poor vision, poor color vision, photophobia, and nystagmus. Symptoms and signs identical to the last case with achromatopsia. The fundi are normal, the autofluorescence is normal, but straight away we can see from the rod ERG this is not achromatopsia. The dim flash rod ERG is present, but it's subnormal. There's been a loss in rod system function. The strong flash ERG A waves are preserved, so we can exclude rod photoreceptor disease, but these waveforms are electronegative, indicating dysfunction that's occurring after phototransduction. The whole of the waveform has a negative aspect. It's below the baseline. The severe involvement of the cone system, the flicker ERG is markedly attenuated and perhaps just slightly bifid in shape, and the single flash cone ERG has a very low B to A ratio. So this is a little bit more severe than in absolutely typical cases, but nevertheless, most in keeping with the incomplete form of CSMB. And in this particular family, in this particular patient, I should say, due to mutation in a gene called calcium binding protein 4. There's a homozygous deletion. So incomplete CSMB, more typically, more often, is X-linked, related to mutation in CACNA1F. There's typically marked cone system dysfunction, and we can explain that by the on-off ERG that shows B wave and D wave reduction. Both the cone on and off bipolar systems are affected. Whereas in the complete form of CSNB, there's complete attenuation of the rod ERG, the strong flash ERG is electronegative, there's milder changes in the photopic responses explained by selective reduction in the cone on bipolar contribution. These are the ERGs you'd expect if you could extract the on bipolar contribution from the ISCEV standard ERG. And we can explain these, we can relate these findings to the molecular biology. The two genes implicated in incomplete CSNB are expressed on the presynaptic membrane. So these genes modulate glutamate release, so there's both on and off bipolar cell dysfunction. Whereas all 5 genes implicated in the complete form of CSMB are expressed in the on bipolar cells. So you get selective on bipolar cell dysfunction. So complete and incomplete CSMB. The short wavelength flash ERG or S-cone ERG, a short wavelength flash superimposed on a longer wavelength background. The ISCEV Extended protocol for the S-cone ERG was published just last year. In healthy individuals, it typically has this twin-peaked waveform, and it's the later component that is mediated by the S-cone bipolar cells. A typical clinical application would be in the differentiation between achromatopsia and S-cone or blue cone monochromacy. Clinically, these disorders can be quite similar. The ISCEV standard ERGs can be very similar, but in S-cone monochromacy, the S-cone ERG is relatively preserved. Compare this with this example in achromatopsia. A 12-year-old boy with nyctalopia and poor color vision. Visual acuity is preserved, but there's these deep pigmentary lesions around the arcades that manifest as low density signal on fundus autofluorescence imaging. There's foci of high density, internal and eccentric to the arcades. The dim flash rod ERGs are undetectable, but the strong flash ERGs, relatively preserved in terms of amplitude, about 300 microvolts of B wave. So how do you reconcile an undetectable rod ERG with a 300 microvolts of strong flash ERG B wave? In healthy individuals, these components are dominated by the activity of the rod bipolar cells. So it's difficult to explain. Also, can you see how the A waves are simplified and profoundly delayed, even more delayed than in typical cases of retinitis pigmentosa? In healthy individuals, the flicker ERGs typically have an amplitude between that of the single flash cone ERG A wave and B wave. In this individual, the flicker ERGs are smaller than the A wave, almost a pathognomonic feature in itself. And in fact, this pattern of abnormalities specifies one diagnosis. The S-cone ERGs are typically enlarged, at least in a high proportion of cases, and the shape of the waveform is basically very similar to a single flash, irrespective of whether the retina is light or dark adapted. Findings typical for enhanced S-cone syndrome. And we can relate the ERGs to what we know about the histopathology. These patients are born without rods, so there's no dim flash rod ERG. Remember, this response is selective for the rod system. The flash is below cone system threshold. They have an abnormally high number of cones that mostly express S-cone opsin. So essentially, the dark adapted and light adapted single flash ERGs are abnormally large S-cone mediated ERGs. Now, this is just a sample from our normative database showing how the strong flash ERG A wave declines with increasing age. In enhanced S-cone syndrome, you can see there's wide variability in the amplitude of the strong flash ERG. But the mean rate of age-associated decline is very similar to that seen in the control group. Similarly, peak times are relatively stable across about 6 or 7 decades. Similarly, for the cone ERGs, there's wide variability, but no evidence of accelerated decline with age. Now, I'm showing you those slides partly to illustrate the variability in the ISCEV standard ERGs in this condition. They can be very small, particularly in older individuals. And the point is, the S-cone ERG alone cannot make the diagnosis reliably in every patient. In patients with small ISCEV standard ERGs, the S-cone ERGs can also be small, but proportionately large compared with the single flash cone ERG A wave. It's the ISCEV standard ERG you need to make the diagnosis reliably. Okay, so just a summary, just to highlight some of the conditions that benefit from testing with these ISCEV extended protocols. I've only mentioned these 3 protocols. I would highlight, in total, there are 8 extended protocols. Suresh Viswanathan will talk about the photopic negative response, I think, in the next session. And these other techniques can also be useful, but perhaps more for experimental and deep phenotyping purposes. Thank you.
Okay, thanks very
much. Thank you,
much,
Dr. Tony, for your talk. I think next we go on to Dr. Omar Mahroo's talk on the electronegative waveform.
Okay, and he has sent a video pre-recording of his talk, so we'll be playing that next.
We're going to talk about the electronegative waveform. We've only got 15 minutes, so we can't cover everything, but I just want to point you towards this review that we published a few months ago, which goes into the subject in a lot more detail, and it's open access, so freely available. This is the outline of the talk. We'll recap the physiological basis, prevalence in different patient cohorts, the different causes, genetic and non-genetic, some questions that can help make the diagnosis, an illustrative case, and some concluding remarks. So this is the dark adapted bright flash response that we know and love with the A wave and the B wave. These are the main players, the rod photoreceptor and the rod bipolar cell. In the dark, there's a circulating current going into the outer segment of the photoreceptor, keeping it depolarized and causing glutamate to be released at the synapse to the rod bipolar cell. When light hits the photoreceptor outer segments, phototransduction is initiated, and that culminates in closure of the cyclic nucleotide gated channels in the outer segment, which causes the cell to hyperpolarize, become more negative. And that gives rise largely to the A wave, all those millions of rod photoreceptors hyperpolarizing. And there's a reduction in glutamate release at the synapse, and the rod bipolar cell then depolarizes in response, and that bipolar cells becoming more positive, less negative, gives rise to the B wave. So clearly any problem with the rod bipolar cell, either because it's degenerated or because it's not not generating the electrical signals, or any problem at the synapse, even on the presynaptic side, will selectively attenuate the B wave and give rise to a negative waveform. The other thing that's useful to look at is the light adapted single flash response, which looks like that. It's a little bit more complicated. It's coming from the cones, but also the cone driven on and off bipolar cells, whereas rods only signal to on bipolar cells. And here, if you lose the on bipolar cell response selectively, then you get a waveform that looks a bit like that. So a broadened A wave trough, a sharply rising B wave. And here's a list of possible causes. So this happens in complete congenital stationary night blindness, and that's caused by variants in a handful of genes. And acquired causes include melanoma-associated retinopathy, importantly, and in that condition, antibodies are formed to TRPM1, the protein that's encoded by this TRPM1 gene, which is also mutated in complete CSNB. So that explains why they are electrophysiologically identical, although obviously on the clinical history, one can easily distinguish them. So complete CSNB patients have lifelong night blindness. They're often highly myopic, and they may have nystagmus. A melanoma-associated retinopathy would have recent onset of night blindness, recent onset of symptoms, maybe photopsia, other visual problems as well. And then if you were to lose both on and off bipolar cell responses due to a problem at the synapse, at the presynaptic side of the synaptic cleft, then you get a much more attenuated light adapted waveform, which is sometimes even electronegative. And this is encountered in terms of genetic conditions, incomplete CSNB with mutations in either of these genes. And other causes include central retinal artery occlusion, which would also take away both the on and off bipolar cell responses, but the photoreceptor responses, the photoreceptors are supplied by the choroid, not the retinal circulation, so they would be intact. Finally, before we leave the physiology, should you have a problem in the rod photoreceptors themselves, such that none of the rods are really responding or very few, and you're mainly getting a cone system response in the dark, you can get a negative looking waveform. But here the A wave is much reduced, but the B wave may still be smaller than the A wave. And that's just the way the dark adapted cone system response is in some people in response to a bright flash. Normally you don't see that because in a healthy person you've got the big rod system response, but if you've lost that selectively, then you may get this sort of waveform. So importantly, that the reduction in the A wave gives you a clue that the problem is with the rod photoreceptor and not a bipolar cell or inner retinal problem. So we define an electronegative ERG as a B wave smaller than the A wave. It's best seen in the dark adapted bright flash. The A wave should be of normal size, and then an electronegative waveform will indicate post phototransduction problems. If the A wave is reduced, then that would tell us there's a problem with the rod photoreceptor, so it's a different differential. It doesn't tell you that there's inner retinal dysfunction necessarily. How prevalent are electronegative ERGs in patient cohorts? Obviously, it depends on the prevalence of different diseases and local referral pathways. But in these studies, it was roughly 3 to 5% of ERGs in practice were electronegative from patients referred for electrophysiology. And here's a table summarizing the different causes. There's another cohort added on the right. And the big causes to know about are X-linked retinoschisis and congenital stationary night blindness, CSNB, as a host of acquired causes. You'll see also here photoreceptor dystrophies listed. That can give rise to a negative looking waveform, but here the A wave would be subnormal as well. So when we go to causes, we can split them into genetic or non-genetic. Generally, genetic causes, monogenic diseases, inherited retinal diseases, affect both eyes symmetrically. With the non-genetic causes, they could be unilateral or bilateral and often asymmetric. Here's a list of genetic causes. The key ones to consider that give rise to an electronegative waveform are highlighted by the red square here, or rectangle, in the yellow writing. So there's complete and incomplete CSNB, which have been mentioned. Importantly, the waveforms you get in those two conditions can really narrow down the differential to just a few genes. And certainly if you've got a male with an X-linked history, then it narrows it down to one gene. If the waveforms look like complete CSNB, you know it's NYX. If they look like incomplete CSNB, it's CACNA1F. So together with the family history, you can sometimes narrow it down to a single gene. And then we also have X-linked retinoschisis here. The ERG isn't always electronegative. Sometimes there's just a reduced B to A ratio in X-linked retinoschisis. Rarely the full-field ERGs can be within normal limits. And on OCT, one sees schisis at the macula. In older patients, sometimes the schisis has resolved and you just have some thinning, non-specific thinning or outer retinal atrophy at the macula. In terms of other genetic causes, we're increasingly appreciating that CRX, a gene associated with a dominant retinal dystrophy, can frequently give rise to a negative ERG. Not always, often it isn't electronegative, and sometimes the A wave is also subnormal, even when there is a negative looking waveform. And then there's a couple of other diseases in which the A wave is subnormal, so it doesn't meet our normal definition of electronegative ERGs. Because the A wave is subnormal, and here it's because you've lost the rod system response and you're seeing the dark adapted cone system response. There are some neurodegenerative conditions that can be associated with a negative looking waveform. The one to highlight is juvenile Batten disease associated with variants in the gene CLN3. I'm highlighting this because these patients may present to the ophthalmologist first before the pediatrician or the neurologist. And vision is rapidly declines from the ages to say between 4 and 8, and then the neurological symptoms ensue afterwards. You can see a negative waveform, sometimes the A wave subnormal as well, and sometimes there's an undetectable ERG depending on the stage. But it's a diagnosis not to miss because it's so tragic in that these children develop neurological symptoms, a progressive degeneration, and death ensues in early adulthood or in teens. These are some examples of ERG waveforms in some of the different genetic conditions. So complete healthy control on the left here. These are ISCEV standard ERGs. Complete and incomplete CSNB are distinguished by whether the dim flash B wave is completely or incompletely abolished. And also looking at the light adapted ERGs, they're far more attenuated in incomplete CSNB, as we mentioned. And this is a patient with X-linked retinoschisis. ERGs can be variable, and as we've said, sometimes not even electronegative in that condition. So if you do have a male with an X-linked non-syndromic retinopathy and bilateral negative ERGs, and you know that there's X-linked inheritance, you can go through a simple little algorithm here and get it down to one G just based on the OCT features and the findings on other standard full-field ERGs. There's a review we published this year encompassing all of the X-linked retinopathies. We have this very complicated algorithm that if you have a male with a non-syndromic retinopathy and an X-linked pedigree, you just go through these steps and you can narrow it down to a single gene or a couple of genes. And in some of these cases, it's the electronegative ERG that helps very much with the diagnosis. This is, before we leave genetics, this is Gucci disease, recognizable with this remarkable sheen in the retina. And here the rods are basically aren't switched off, so they're not available to respond electrically to light. So these patients are night blind, and the ERG has a negative looking waveform, but the A wave is very much reduced. You're basically seeing the dark adapted cone system response. So again, here the problem is with the rod photoreceptor. Now moving on to non-genetic diseases, there's a whole list here. You could categorize them as vascular, toxic, either systemic or direct ocular toxicity, autoimmune or inflammatory. And then I've got nutritional here, vitamin A deficiency. That really affects the rod system far more than the cone system, and that's why the dark adapted waveform can look negative, but that's because you're seeing the dark adapted cone system response. The cone system is much more robust in vitamin A deficiency. vascular retinovascular disease can give you a negative ERG because the choroidal circulation keeps the photoreceptors intact whilst the inner retina degenerates. And just within the inflammatory conditions, stroke autoimmune, an important category is paraneoplastic autoimmune retinopathy. As we've mentioned, melanoma-associated retinopathy gives you a selective on-pathway impairment, very characteristic ERGs. In carcinoma-associated retinopathy, they can be variable. You can get different reductions in the A wave or the B wave, not necessarily a negative ERG. Some questions to ponder then when making the diagnosis. ERG-related questions. Is the problem unilateral or bilateral? Is it symmetric? Is the A wave normal, as we've said? And what does the rod-specific dim flash B wave look like? What's the shape of the photopic responses? And also, of course, as a patient attached to your ERGs or producing your ERGs, so the clinical history, the family history, the appearance on multimodal imaging will help clinch the diagnosis. I have that in much more detail in these tables, but they're in the review and we don't really have time to go through them now, but features in the patient history or on retinal imaging or relating to the ERGs and tips for getting the diagnosis. Let's do an illustrative case. Here's a Caucasian male in his late 70s, some vague visual symptoms, a bit of night blindness, some mistiness after cataract surgery. The other cataract was done, still no improvement, had some cardiovascular problems, no real family history of note, on some common medications. So no improvement after cataract surgery, no cause found. He was referred to GTP, that's not guanosine triphosphate, as I'm sure you thought it was. It's my colleague Gordon Plant reviewed this patient and found the fundus looked clinically not really remarkable. Visual acuity was subnormal, anterior segments were unremarkable, and there was a visual field defect, central scotoma or centrocecal scotoma in the other eye, and not completely normal looking fundi, but nothing very specific. On OCT, some thinning, mainly of the ganglion cell layer, more marked in the other eye, but the outer retina doesn't look too bad. Fluorescein didn't really add much, just showed some late vascular leakage. Blood tests were unremarkable, and going to the ERGs, this is a normal response on the left to this scotopic dim flash, and the patient's responses were undetectable. He had an electronegative bright flash ERG. The light adapted responses were attenuated as well. And interestingly, in the right eye, he had a waveform suggestive of predominant on-pathway loss, maybe not so much in the left eye. So when we look at our differential, a lot of these things don't apply based on his imaging and clinical history, but we need to worry about autoimmune or paraneoplastic retinopathies. And indeed, his initial electrophysiology was reported by Tony Robson, and he worried about melanoma-associated retinopathy or carcinoma-associated retinopathy. That prompted further systemic investigations, which revealed on a CT PET scan active nodes in the left axilla. A biopsy showed that was a metastatic melanoma. The primary was still to be found. He was reviewed by the melanoma service, and a primary was found on the back, which was excised, and he was treated, and now he's in remission some years later, although his visual symptoms unfortunately persist. So in conclusion, the electronegative ERG is an important finding. There's a handful of genetic diseases that are associated. So when you see an electronegative ERG in the context of genetic disease, it's really helpful because it can guide genetic screening. These days, we don't screen one gene at a time. We do large multi-gene panels or even whole genome sequencing, and often that throws up a whole host of variants in different genes. And it's really the phenotype in particular, which includes the ERG, that can really tell us which genes we should be focusing on and which variants are relevant to this patient's disease. In the context of non-genetic disease, as we've shown, it may point to different diagnoses, including paraneoplastic retinopathies. And in some cases of MAR, like the case I've shown, the visual dysfunction may precede and even prompt the search for a melanoma. And hopefully by detecting those lesions early and early treatment will have a positive impact on patient survival. So thank you very much, and I'm happy to take questions and also receive emails if you have any queries. Thanks again.
Thank you, Dr. Mahroo. I'll take this opportunity to introduce our speakers We could not introduce them before their talk. We had Tony Robson, Dr. Tony Robson, who presented us an excellent talk. He currently leads one of the largest electrophysiology department worldwide. He's the director of standards for the International Society for Electrophysiology and Vision, and he's an honorary associate professor at the UCL Institute of Ophthalmology, London. Thank you, Dr. Robson. And also we had the opportunity to hear Dr. Omar Mahroo. He's a professor of retinal neurosciences, University College London, and a consultant ophthalmologist at Moorfields Eye Hospital. I thank you for their excellent talks. The session is open for questions. We have got a lot of questions from our attendees. I'll be asking them. Before I go into the attendees, I'll ask our panelists, Dr. Dhanashree Ratra, Dr. Chetan Rao, and Dr. Vinod to make their comments or if any questions they have.
I just typed the question. I was just wondering, I mean, it's to Dr. Tony as well as Dr. Omar. Are there any systemic conditions that can actually affect the ERG responses? I mean, even normal ERG responses. Is there any systemic conditions that we should note when we do, before we do an ERG? I mean, pathological ERGs, as you have shown very clearly, they have very typical patterns. But does, like, for example, the amplitude of the ERG, does it make any systemic condition that we should know of before? I mean, does it affect the ERG responses in the eye?
Well, I guess, many conditions, many systemic conditions can be associated with ocular disease. And in those conditions, you might expect an abnormal ERG. In the context of electronegativity, one that springs to mind is phosphomonomutase deficiency, which is an abnormality of glycosylation. I guess in diabetic retinopathy, it's not uncommon to see manifestations of inner retinal ischemia. In Batten disease, a neurodegenerative condition, as Omar has mentioned, there can be an electronegative ERG. Vascular paths, I guess, are prone to vascular occlusions, and that often causes unilateral or asymmetrical inner retinal dysfunction, which can manifest as an electronegative ERG.
Yeah, and just to add, so Duchenne muscular dystrophy, interestingly, many of those patients have a reduced B2A ratio or a negative ERG without seeming to have much in the way of visual dysfunction. But as Tony said, most of the conditions that affect the ERG will give you a retinopathy or something you might, or it's a neurodegeneration that affects the retina as well. There are very few I can think of that we don't really affect the retina as we know it, but can have an effect on the ERG, apart from maybe Duchenne muscular dystrophy, that they can have negative ERGs.
Thank you. We have a question from the audience for Dr. Tony Robson. What additional information is provided by the dark adapted 10.0 ERG? Should it be done in all patients?
Yeah, I would say it's essential, actually. And I think, probably more useful than the DA3 ERG. The DA3 ERG is retained within the ISCEV standard, partly to allow direct comparison with legacy data. But the DA10 ERG, the A wave is often better defined, it's easier to characterize, it's larger, and importantly, it's of shorter peak time with a slightly dimmer DA3 flash. If it's of shorter peak time, then proportionately, it will have a larger rod photoreceptor contribution than to the DA3 ERG. So I think it's really important for assessment of rod photoreceptor function. As Dr. Sen mentioned, the oscillatory potentials are often enhanced, and it can better expose electronegativity in a low B2A ratio, and also useful if there's mild to moderate media opacities. It's less attenuated. Responses will be less attenuated to the stronger flash. Having said that, I would always perform both, because when you do ERGs, patients are not robots, and there's often artifacts, and always you're looking for consistency between responses. If the dim flash ERG is abnormal, is the DA3 abnormal? Is the DA10 abnormal? Similarly, for the phototopic ERGs, you're always comparing single flash and flicker ERGs to look for consistency. So I think both are important, but if I had to drop one, I'd drop the DA3 ERG.
And just to add, Tony, the B to A ratio in normal healthy people will be lower normally in the DA10 than the DA3. So it's important to have your normal range for the DA10 as well.
Thank you very much. We have one more question. In a routine clinic, in which conditions would you advise a long duration flash ERG, scotopic red ERG, S-cone ERG? Any particular finding in ISCEV ERG that, if seen, will prompt you to do these extended tests?
I mean, I think, the dark adapted red flash ERG can be done very quickly and can easily be inserted within a routine protocol. So I would suggest performing it routinely, because you can't always predict what the ISCEV standard ERG phenotype will be. And again, always useful to look for consistency. If the dark adapted and light adapted ERGs are abnormal, is that reflected in the red flash ERG? There is one condition where the red flash ERG is essential for diagnosis, and that's a condition known as bradyopsia, or RGS9R9AP retinopathy. That's a condition where there's abnormal deactivation of arrestin after phototransduction, and it's a very peculiar pathognomonic ERG phenotype where the dark adapted red flash ERG is normal, dark adapted cone function is normal, but light adapted cone function is grossly abnormal. And when you show the flickering stimulus, there's very rapid, severe attenuation of the flicker ERGs. And under dark adapted conditions, you often have to extend the interstimulus interval of successive strong flashes to elicit a normal amplitude response. So in that rare condition, the dark adapted red flash ERG is essential. As for on-off ERGs, I think a very useful addition to routine phototopic testing, but particularly if there's a suspicion of inner retinal dysfunction. So complete CSMB, incomplete CSMB, exon retinoschisis, MAR, carcinoma associated retinopathy, autoimmune retinopathy, some retinal toxicities, any condition where there's an electronegative ERG. And as electrophysiologists, we talk about complete and incomplete CSMB a lot. We go on about those conditions a lot. It's not just so we can characterize those conditions. It's because we understand them quite well, so we can compare other disorders with those very characteristic phenotypes. And we can help sort of understand better the pathophysiology. So I think an on-off ERG in those circumstances would be very useful.
So, Dr. Tony, if I may also ask a question. See, very often I presented the pathognomic ERGs which could be present, but I purposely did not mention about bradyopsia because, to be honest, we have never diagnosed it. The reason because of which we have never diagnosed is because, as you said, unless you perform a special test, we are not going to be able to diagnose bradyopsia on a standard ISCEV ERG. So what do we see in a standard ISCEV ERG report which should prompt us to do an additional step here so that we can diagnose this condition? Or is it real?
In the context of bradyopsia?
Yes, is it so rare
So as
that
I mentioned, I think it's really useful to introduce the red flash ERG into your standard ERG protocol. It takes seconds to record, so why not include it? But I guess the ISCEV standard ERGs and bradyopsia resemble those associated with achromatopsia, except the strong flash ERGs can be a little bit more attenuated than you might expect. And I think the patient's history and symptoms may also give a clue as to what sort of testing is needed. Patients with a bradyopsia are not profoundly photophobic. They complain of problems adapting to light and adapting to dark. And they have poor motion sensitivity. and that can also give a clue as to what electrophysiological investigations are needed to better sort of interrogate the pattern of dysfunction. I don't know if Omar has anything to add.
I'd like to add, if I may, Tony, if you do an intensity series in a standard ERG, then with the RGS9 mutations, as you get brighter, you find that instead of the ERG getting larger as it should do, it gets smaller because, as you correctly mentioned, the delayed recovery. And if you do 2 bright flashes in a row, for example, DA10, and you always have to do replication for the ISCEV standard, the response to the second flash will be of lower amplitude than the response of the first flash, unless you increase the interstimulus interval up to 45 seconds, maybe a minute. So you can get it without the red flash, but of course the red flash, as you know, I am a great proponent of. Another comment that I may make, if I may, is in terms of terminology, whether we should be using the term negative ERG to what I regard as a pseudo-negative ERG when it's coming from dark adapted cones. Because when we use the term negative ERG, there's an implication that it's in a retinal rod system dysfunction. And we proposed in the American Academy book that if it's due to dark adapted cones, then perhaps it should be called a pseudo-negative, because the implications for the underlying pathophysiology are different. Omar, you did the negative ERGs, what do you think?
I agree, yeah, and hopefully I did mention it in the talk, I can't remember that. Yeah, as part of the definition, the A wave should be of normal amplitude, and when it's subnormal, as you say, it's a different differential, and it tells you there's a problem with rod phototransduction, so I completely agree. I guess sometimes if you're working back from the diagnosis, you know, sometimes you see an ERG and you see a negative looking waveform, so it may be reported as a negative waveform, and maybe the A wave subnormal, but still within normal limits if it may be subnormal for that patient. So you don't always know a priori that it's pseudo-negative, but I completely agree that if we keep the definition as a normal A wave with a subnormal lower B wave, then that immediately points you to the right differential.
So just one more comment. When we do the long duration ERG regularly in our patients, such a long duration flash, does it alter the dark adapted condition of the patient? Do we have to make some changes there?
So the on-off ERG is a photopic light adapted response. So it can very easily be added at the end of photopic testing. But I think, you know, if you perform the light adapted responses first and then dark adapt patients, it really makes little difference after 20 minutes dark adaptation. No difference.
So we finish all the tests and do it at the end so that it doesn't alter the dark adaptation.
I think you can add it at the end of photopic testing.
On a regular basis, yes. Thank you. Rupak, any more questions?
Yeah, no, thank you very much. Though we can discuss more, but we have a tight timeline to follow. Thank you all the presenters for their excellent presentation. I hand it over to Dr. Parveen to take us to the next session.
Okay, thank you.
Thanks
Thank you, Dr. Thank you, Dr. Omar, for the excellent talks, and Rupak for the panel discussion. So if there aren't any further discussion points, I would like to invite Dr. Mona Bhende. She is the Deputy Director of Vitreoretinal Services in Shankar Nethralaya and a very keen medical retina as well as a surgical retina specialist. Ma'am, over to you for the next session.
Thank you, Parveen, and good evening, everyone. We will be starting the next session after that very interesting session on the basic electrophysiology techniques and also extended protocols. And this session will be on electrophysiology in specific retinal conditions. May I invite Dr. Stuart Coupland to be our first speaker on multifocal ERG in screening and follow-up of HCQ toxicity. Dr. Coupland is a clinical investigator of the Regenerative Medicine program at the Ottawa Hospital Research Institute, and he is also associate professor in the Faculty of Medicine, Department of Ophthalmology in Cellular and Molecular Medicine, with an interest in study of retinal function and structure in patients with AMD and macular pathologies, and development of sensitive screening techniques. So welcome, Dr. Coupland, and we look forward to listening to you.
Thank you. Thank you very much. Okay. Do I have audio? Can you hear me? I don't know if I'm connected or not. Natalie, do I have audio out there?
We can hear you.
Oh, okay. I do apologize. Okay. I'm clicking on the image, but I don't see my thing moving here. It's not. It doesn't go to the next slide. Okay, I think we've got something happening now.
Yes, something moved. So you can proceed.
Yep.
Stuart, hang on one sec. I'm going to turn off the laser pointer because that's given people difficulty before. Try now. You should be able to control it now. There you go.
Perfect. Thank you so much. Today I'm going to talk about multifocal ERG screening and follow-up of patients who are on hydroxychloroquine. Chloroquine and hydroxychloroquine, or the drug name is are used to treat rheumatoid arthritis. Patients on these medications are typically on these medications for a lifetime. Approximately 10 to 20% of patients do develop toxicity and have to be taken off the drug. Approximately 5% of the patients who receive hydroxychloroquine therapy develop toxicity. So overall, hydroxychloroquine therapy is a much safer and tolerable therapy than the original standard, which was chloroquine therapy. The dose-related retinopathy is an overall maculopathy, and shown here. The ocular symptoms include decreased visual acuity, visual defects. Vision loss is irreversible and progresses after the patient has taken medication. The American Academy of Ophthalmology standards on screening for chloroquine and hydroxychloroquine retinopathy have suggested that the multifocal ERG may be useful in detection of early toxicity. My talk is briefly going to talk about how multifocal ERG is clinically interpreted to detect early toxicity. This is a normal multifocal ERG trace array to 61 hexagon stimulus. We use the diagnosis system, and there are other systems that produce equally good results. This is on the left is our normal, and on the right is a typical patient with plaquenil toxicity. I think you can see that the traces are reduced centrally, more so than the peripheral responses, traces. And this indicates, of course, toxicity. Interpreting the traces, typically the clinician has to decide whether they're normal, abnormal, mildly abnormal, or extremely abnormal. And this is based on the fact that we have normative data in terms of the amplitude and time of these responses for each of the traces. Clinicians report whether they are reduced or delayed, both reduced and delayed. what is the pattern of the abnormality? Is it just in the central region? Does it include peripheral reduction or delay of these responses? Is it scattered? And are there altitudinal defects? These are the ring averages from 5 rings, going from 1, 2, 3, 4, and 5. The first is the macular region, the central macular region. The second is the parafoveal region. Choice 3 is a mixture of parafoveal and more peripheral responses in 4 and 5. The ring averages have normal statistical of 1 or 2 standard deviations, which is displayed by the software, which makes it very easy for the clinician to make to see whether this patient's responses fall within the box, or in this case in the parafoveal region, outside of the box. These are, in this case, these are 2 standard deviation normative data distributions, and it makes it very simple to for the clinician to assess from the multifocal ERG printout whether these responses are within normal limits or borderline or outside of normal limits. So that's a foveal, parafoveal. This is a mixture of parafoveal and paracentral, and the paracentral responses. Interpreting the ring averages, as shown here, we look at the peaks of the response, and we can see that here in ring 1, 3, 4, and 5 are lower than normal ones. Ring 2, which is the parafoveal region, represented in here the actual printout of the traces. This is the parafoveal ring 2, and in this case, it's quite clear that the ring 2 peaks fall outside of the normative data range. The next thing that we look at is the topographical map. Now, these fancy colorized 3D images give us another depiction of the degree of reduction in response density. And here we see that this is a normal response function from a patient. And this patient was unique in that they had a normal eye and also had early toxicity. This is an example of a normal response. One can see that the topographic distribution of the response density is peaks in the foveal ring and diminishes and stays normal across the peripheral rings. And so this gives it a very easy interpretation for the clinician to make by looking at the previous raw data and the 3D modeling. This is the other eye. This patient, they had a normal response function from the ring eye, and they had a reduced function in the other eye. And the reason I'm showing this case is because it's an extremely unusual presentation. Typically, we have both eyes will be very similar, and I'm using this just for presentation value to show that you can get situations where patients patients have normal function in one eye and subclavicular toxicity in the other. And this is a perfect example. I don't see this very often in my practice, but we do occasionally. And so when it does occur, it's quite unusual. And here is the patient's actual data. Here we're showing the trace arrays are shown here. And in the normal eye, you can see that the peaks are very good. This is the actual trace array average. And you can see that this is, these are 1 standard deviation and 2 standard deviation units. And you can see that the foveal and parafoveal and paracentral responses all fall within normal limits. In this eye, however, in this eye, you can see that there is a reduction. Certainly in the parafoveal region, it is 2 standard deviations from normal. And so this type of display is very useful because you get to see the actual distribution of the data. And this gives you the 3D topographic mapping of the normal eye, the eye with evidence of plaquenil toxicity. Now, this eye isn't showing the toxicity is an interesting feature because it occurs very infrequently, but it does occur, and that's why I was presenting it for this presentation. Thank you.
All right. Thank you, Stuart.
Thank you, Dr. Coupland, for a very nice talk, and I think even the novice attendees would have been able to understand how to interpret the multifocal ERG. And I would now invite the next speaker.
Okay, so Dr. Rupa has provided me a recording of her talk, so I will be putting that up now.
I would like to invite Dr. Rupa Anjanamurthy from Arvind Eye Hospital, Madurai, to give her talk on pediatric electrophysiology. Welcome, Dr. Rupa.
Good evening and good afternoon to all. I'm going to speak on pediatric electrophysiology. I would like to thank the BioMedix, Diagnosys and Dr. Parveen Sen for giving me the opportunity to talk in this webinar. Vision is a true miracle of neural processing. Great deal of infants' learning is through visual mode. Coming to learning objectives, first we'll talk about the evaluation of visually impaired infants. That is the most important step in any impaired infant's examination, because we have to arrive at diagnosis. It makes us very difficult. After an evaluation and fundus evaluation, all of us are worried what next, whether is it ERG or is it VEP or is it brain imaging. There are 5 electrophysiological tests of the visual system as I have listed here. Actually they are non-invasive. They provide an objective indication of the function in millisecond resolution. Mostly we will be doing full-field ERGs and VEP for infants and children. Rest EOG in cooperative patients. Coming to pediatric electrophysiology as such, we have lot of challenges in handling these children, like many concerns, like what will be the patient's position, recording electrodes, maturation of ERG, decision, sedation or anesthesia, or can we do it under topical anesthesia. Finally, the decision making by technicians and physician matters. When to do ERG and VEP? When ERG in infants, that is when they have a very poor vision since birth, nystagmus, excessive light sensitivity, staring at lights and ocular digital sign. Above 2 years, mostly they belong to the inherited retinal diseases, and any child with decreased visual acuity and fields, and most of the children who are wearing glasses who do not improve further, even with patching. Development of the visual system is not fully developed at birth. Foveal pit photoreceptors are immature. Myelination of optic nerve, lateral geniculate nucleus, occipital lobes are underdeveloped. Subsequent development and maturation requires physiological maturation and environmental stimulation. Coming to the maturation of ERG, Lower amplitudes and longer peak times are seen in babies below 6 to 12 months in a dark adapted state, and in babies below 2 to 3 months in light adapted state. Dark adapted 3 is poorly defined in healthy infants, and 10- is definitely well defined in infants. So the mean ERG parameters at 6 months are at lower range of adults, and they approach mean adult value by 1 year. So signals from very young infants must be interpreted with caution. And this is one of the study comparing the infant and adults. They see the mean B wave amplitude increases systematically until childhood, whereas the implicit times of B waves except for the rods will decrease systematically until adulthood. If the initial presentation is of infant's ISCEV responses are abnormal, retest data can help confirm or refute. Maturation of VP, the P100 shows a low variability of waveform, a rapid decrease in latency over the first postnatal year, and the larger checks mature faster. Amplitude is highly variable parameter, and age dependent changes are less orderly. In infants with flash VP shows considerable inter-individual variability with complex waveforms and decrease in latency with age. And this one of the study in preschool children showing that there is a decrease in VP latencies and waveform changes. So VP latencies essentially reach adult value by age of 1 year. Monocular pattern reversal VPs have slightly longer latencies than binocular responses. Coming to the adaptations. So we start off with the equipments. We can use an handheld mini Gansfield for both ERG and VP instead of the standard, and the stimulus adaptations for infants like high flash, low slow presentation, high contrast, bigger pattern sizes, multiple recordings will help. Compare with age matched controls always. Coming to the electrodes, although many electrodes are available, the most ideal would be the skin electrodes and the DTL electrodes. The outpatient practices next is the VEP. VEP modifications, it must be compared with the appropriate age-related normal values. Sweep duration should be sufficiently long. Direct interaction with the child is important. 2 testers are beneficial. Child is held in lap or over the shoulder. Binocular pattern stimulation is easier, and you always replicate the VEP. Coming to the OPD practices, we usually use a DTL for uncooperative patients, and we make them supine and use handheld mini Gansfield stimulator. A baby in a mother's lap will be definitely comfortable with skin electrodes, and pediatric Burian Allen for older children. Goal is to create a quiet, calm environment and minimize recording period. And nowadays advanced LED stimulators, that is the color flash handheld with skin, are very popular. And this is a graph showing both GPS and LDS. So they say they're almost the waveforms morphology is similar. Anesthesia, the most concern about sedation or anesthesia is child may slip from sedation to deeper state. VEP waveforms are more susceptible. Propofol can cause 50% reduction in scotopic ERG, 10% increase in light adapted B wave and 30 Hz flicker time. Interpretation of B waves under anesthesia should be done carefully. And this one study shows that propofol and sevoflurane has little effect on the amplitude of ERG, whereas both decrease the amplitude of VEPs, but propofol had lesser effect. ERG recording at our institute at 1 year to 5 years at our institute. So what we do is we have an anesthesiologist attending the ERG recording, and either we use the ordinary Gansfield or an handheld this one. So the child is dark adapted along with the dilating drops are instilled. After that the anesthetist will give injection ketamine 1.5 milligrams per kg body weight and injection midazolam 0.5 to 1 milligram per kg body weight. Airway is maintained but no intubation is required, and we continue to do all the ISCEV steps, and this is one which is being recorded with ketamine. Finally, we will complete the test with the indirect ophthalmoscopy, if possible a fundus photograph also. So this is the flow chart showing the sequences of examination. Coming to the case scenarios, we have a severe child who was referred for a glycine encephalopathy, and this is a recording of the VEP. It shows that there is a waveform morphology and latency delay when compared to this one, but one comforting this one is that the waveforms are well formed. At least they are seen properly, saying that the visual pathway is intact. And this is yet another CVI child with periventricular leukomalacia, fundus and VEP is showing a normal study, which is really comforting the parents that the child might get good visual acuity later. But only caution is that the VEP might overestimate the visual acuity. This is a child with optic nerve glioma who came for a routine checkup and who had an anterior segment findings of lesion nodules, and when we did an MRI we found that she had an optic nerve glioma, and we followed up the child for 1 year with VEP. Almost the VEP remained same. So the most important thing was that she was 8-year-old. The aggressive tumors are seen below 5 years, and VEP is a sensitive and cost-effective screening and monitoring progression of optic nerve gliomas in neurofibromatosis 1. This is a child with LCA, 6-month-old, with all the anterior segment changes, and this is a normal, almost near normal fundus, and see that the ERG is flat. And we also did a study with for clinical exome sequencing of these LCA children and found many genetic heterogeneity. And most important I want to tell is novel mutations in LCA5, CRX and CEP290 was seen, and we also reported PRPH2 and CEP290 and ALMS1 for Indian population. This is one of the PRPH2 mutation which we saw for the first time, showing a vitelliform egg-like lesion in a 4-year-old child. And we have to always think about the systemic associations along with LCA, always rule out systemic associations. And many syndromes like Joubert syndromes, Alstrom syndromes, mostly we see these two very commonly, rest are not so much commonly seen. And coming to RP, this is a non-syndromic RP with the night blindness in a 5-year child, showing an extinguished ERG and a nice autofluorescence ring at the macula. This is a syndromic RP with Usher syndrome, 10-year-old with the cochlear implant at 1 year of age. And the patient had a similar like a RP picture, like a nice autofluorescence ring around the fovea, and a flat ERG. Bardet-Biedl syndrome, of course, this is one of the important syndromes where we have to be very careful about the systemic symptoms, similar flat ERG. And the challenges in these pigmentary retinal degeneration is that the early to present will be the ocular symptoms, and later a full-blown systemic disease can occur. Achromatopsia, we can see that the cone function is completely absent. This child was there with high frequency nystagmus. Vigabatrin toxicity, many a times we have been referred for vigabatrin toxicity. When compared with the normal, this child was followed up for 2 years. Slowly the cone amplitude started decreasing. So we have to inform the physician regarding the so. Stargardt's disease, why we want to talk about Stargardt's is most of these children are treated as malingering patients. Only when we do an autofluorescence we can pick up this flex. And sometimes the ERG also shows us whether the cones are affected or rods are slowly decreasing in the size. Best retinopathy, most important thing which I want to show is that here EOG will apply a lot, and it is diagnostic in diagnostic purpose is very well served with seeing that there is absent late rise. So there is another patient with same EOG finding, absent light rays. Incomplete CSNB, we can see that there is a negative pattern, and in a complete CSNB again a negative pattern of ERG. And most important thing which I want to say about CSNB is most of the myopia patients might present without knowing that they have a CSNB patient. So when they don't improve further on, you have to do an ERG. This is finally to show a benign flecked retina, a 6 weeks vision with 11-year-old child, almost near normal ERG findings. So the take home messages are ERG is of great clinical importance because of the objective nature of the data. It's non-invasive, so this places ERG in a privileged position of diagnostic importance. Always rule out systemic association with any inherited diseases. Thank you.
Thank you very much, Dr. Rupa, for a very nice overview of the applications of electrophysiology in the pediatric age group. I'm sure we'll have some good discussion on this. I would like to invite the next speaker, Dr. Suresh Vishwanathan, from the Department of Biological and Vision Science, State University of New York, College of Optometry. And he's going to speak to us on something that is very new to many of us in the field, the basics and clinical applications of the photopic negative response. Welcome, Dr. Suresh Vishwanathan, to today's meeting.
Thank you. Can you hear me and can you see my slide?
Yes, we can.
Okay. Yeah. Yeah, like Dr. Bhende mentioned, the photopic negative response is the new kid around the block relative to all other ERG potentials. So I'll try to give you some basic introduction to the ERG potential itself and as to what kind of conditions its use has been explored. The photopic negative response, as the name suggests, is recorded under photopic conditions. So we have a bright background which nearly runs the rods into saturation, and you are delivering a flash on top of that. And in addition to the traditional A and B waves, you see this slower negative going potential after the B wave. That is the photopic negative response. And this potential originates from the activity of inner retinal neurons, mainly retinal ganglion cells, and more specifically, it is related to the axonal propagation of action potentials. And the evidence for that comes from primarily initially from animal studies, where the drug that blocks sodium-based action potentials selectively eliminated the photopic negative response, and then followed by studies in animals, non-human primates with experimental glaucoma, where there was verification of retinal ganglion cell loss. The potential was again selectively reduced. And after that, there is evidence slowly started emerging that this similar changes could also be seen in clinical situations. And this is a case of a patient with primary open angle glaucoma, and this is an age-matched control. And of course, the glaucoma was quite advanced in this patient, and you don't need the ERG to actually confirm that there is an optic nerve problem. Unlike the A waves and the B waves, these are much slower potentials, and typically when you're using a brief flash of response, that trough, the PhNR, could be around between 65 and 75 milliseconds, depending upon the stimulus situation. But so this is a relatively slow potential, and so it has been proposed that while the retinal ganglion cells are responding, the glial cells are actually siphoning the potassium that is released, and consequently, it's an indirect reflection of ganglion cell activity. And there is some evidence for that from animal studies, but there is also evidence from some clinical studies. This was a study which was very elegantly performed by Dorothy Thompson and her co-workers. And this is in a condition of E syndrome, where there is mutation of the gene, which actually the gene actually alters the inward rectifying potassium channels, the KIR 4.1 channels on the glial cells. And in these children, you actually see that the PhNR is predominantly reduced relative to the control eyes. What are the best stimulus conditions to record the photopic negative response? Based on studies from several labs around the world, it seems that a red flash on a blue background is the most preferred stimulus. And this has been specifically explored in glaucoma using different combinations of wavelength for test flash and background adaptation. And it seems to be that while PhNR is reduced with almost any one of those stimulus combinations, at least in this disease glaucoma, the red on blue seems to be the most sensitive. And in 2018, a group of us had published the ISCEV Extended Protocol with recommendations for PhNR recording. And I'm not going to go through all aspects, but just highlighting a few things. It's quite important to make sure that the background is bright enough to saturate the rods, but still not too bright to reduce the PhNR responses. While this could be recorded at different flash intensities, ideally when you're using a brief flash, it's you get a large response when you work between 1 and 2.5 photopic candelar seconds per meter squared, but going brighter than 2.5 on this background would actually tend to show a reduction in the PhNR, and this might be associated with something analogous to the photopic Hill phenomenon, which is actually seen with the B wave, which has been reported more widely. Another important thing to remember is the low frequency cutoff of your amplifier. It's preferable to keep it as low, but the problem keeping it too low is you see these other slow drifts. So you could, if needed, actually have that filter at around 3 Hertz or so, but ideally you open it up as much as possible. In terms of measuring the PhNR, the predominant way in which it's been measured is the amplitude of the trough from baseline, but other methods have been employed also where it's measured from the B wave peak or the trough as a measure, this BT, which is from baseline as a ratio of the B wave amplitude. While it might be okay to use these ratio measurements when the outer retina is normal and the B wave is normal, any condition that might also slightly compromise outer retinal function or even the B wave amplitude may give some erroneous, you may, by taking the ratio and not looking at the individual waveforms, you may get to some erroneous conclusions. So the other prevalent method of assessing retinal ganglion cell function is the pattern electroretinogram, and specifically the ISCEV recommended one is the transient pattern electroretinogram. And there are some advantages and disadvantages of the PhNR relative to the PERG. Some of the advantages would be that you don't need to refract your patient, and small deviations in visual fixation does not alter the PhNR that much because it's a full field response. And the fact that in the same waveform, you get an idea of how good the outer retinal function is, and the amplitude could be much bigger than that of the PERG. But the PERG has the advantage that it is a measure of ganglion cells that is coming from the macular region, whereas the PhNR is more of a full field response. So some of the response could be diluted, but the ganglion cell related response could be diluted there. But there are some publications and explorations on measuring PhNR to focal stimulus, roughly the same dimensions as what is used for the PERG. And in fact, while using such a stimulus, it seems that the PhNR as a proportion of the B wave is much larger for a macular stimulation as opposed to a full field stimulation. And as I mentioned, this is a relatively new potential, so there's much to be explored. In terms of the clinical applications, the early applications were all probing its use in glaucoma. And there is also evidence that you could start seeing changes in optic neuritis in MS patients, and even after the inflammation has subsided, you could actually see a subnormal photopic negative response even when the visual acuity has recovered. And clear evidence that in cases of optic nerve compression, the PhNR is reduced, as well as idiopathic intracranial hypertension. And interestingly, it has also been explored in some hereditary degenerations of the optic nerve quite intensely. Leber's is one condition, Leber's hereditary optic neuropathy and autosomal dominant optic atrophy. And in fact, in autosomal dominant optic atrophy, there is actually some evidence that the focal stimulus is able to pick up the situation better than the defect better than the full field. And also at light offset, it seems to, the PhNR recorded to light offset when you use a long stimulus seems to pick up the changes better than the light onset related PhNR. And again, this is one other evidence that using a focal stimulus in the appropriate situation could be more beneficial than the full field stimulus, as these optic neuropathies generally tend to have more of a centrocecal scotoma. And there is evidence emerging that even in very early stages of diabetic retinopathy, when you don't see the standard clinical signs of retinopathy, you could see some compromise of the PhNR, which could be selective, but it all depends on the stage. And then you start seeing B wave changes after a certain point. And obviously, these may be related to compromised blood flow. And finally, there is some evidence that it could be useful in monitoring and predicting visual prognosis. Jonathan Croston in Australia, and I guess Singapore has now actually been doing some work on actually using the PhNR to changes to assess the efficacy of IOP reduction, and there have been some reports from Japan on how the PhNR could recorded in conditions of different conditions of vascular occlusions could be a better prognosticator, and also with studies from Korea on how the surgery for chiasmal compression, the prognosis can be better predicted by the PhNR. So there are explorations underway in various conditions. So, and the jury is still out on and what are all the situations we can actually apply the PhNR to probe ganglion cell function and optic nerve function. Thank you.
Thank you, Dr. Vishwanathan, for that very interesting overview and introducing us to the potential of this new investigation. I'm going to ask you a few questions on the use in retinal disorders in the panel. So may I now invite our next speaker, Dr. Tapas Padhi, who is faculty of the Vitreoretinal Services in LV Prasad Eye Institute, Bhubaneswar. He is our own alumnus from Shankar Nethralaya. He takes care of visual electrodiagnostics in LVPI, and he also has a special interest in retinopathy of prematurity. He's going to talk to us on the utility of the electro-oculography. Welcome, Tapas.
Greetings, audible. Greetings, and I convey my thanks for inviting me to share my thoughts on electrooculogram. I will be in another 20 slides. I'll be taking you through the clinical overview and its role in retinal disorders. In resting stage, we know there exists a potential difference between the base and apical surface of retinal pigment epithelium. So that gives the cornea a positivity with respect to negative behind. So this makes the eye a dipole, behave like a dipole. And this standing potential undergoes a change with the state of dark adaptation as well as the luminance use. As we can see here, whenever we move the eyes between two fixation target, there are a series of square waves, and these square waves, if we plot them, have a sinusoidal pattern, and they reach a minimum around 10 to 15 minutes after dark adaptation, and reach a maximum again 7 to 12 minutes after the light adaptation. And in the absolute corneofundal potential shows marked variation, but however, the light peak to dark trough ratio is constant and clinically more useful than the absolute values. This is how the setup looks like. And there are the skin electrodes are placed on the outer and inner canthi, positive, negative, and the subject after full dilatation rotates the eyes between two fixation targets, and these sockets are made between the dark adaptation of 15 minutes and the light adaptation of another 15 minutes. As we can see here, this is how the report looks like. After looking at the basic demographic data, the compliance, I usually go to these individual sockets, because these sockets will tell you whether the report is interpretable or not. A noisy, the report full of noisy sockets may give erroneous Arden ratio value. Similarly, the next one is the minimum amplitude in dark. Then how the wave pattern looks like. Does it follow a sinusoidal pattern or not? And what is the minimum amplitude in dark, and the light rise is adequate or not, and what is the light peak time? Finally, the light peak to dark drop ratio and its absolute value. These are the ISCEV recommendation 2017. The light peak to dark drop ratio varies from 1.7 to 4.3, and the light peak time in 7 to 12 minutes. And the users are strongly they are urged to establish their own norms with time, and these are the broad ranges. The clinical applications in most of the cases are limited to best vitiliform macular dystrophy with some extrapolated extra vitiliform disorders as well. The picture shown here is a classical picture with vitiliform disorder. As we can see here, the large egg yolk like material which is bilaterally symmetrical, and it is a spot diagnosis of best vitiliform macular dystrophy. We hardly need any extra investigation to confirm. This is, as we can see here, the full-field ERG is normal and there is no light rise. Now the question is the sun going to get affected or not, who has a normal fundus? So here the EOG plays an important role, because EOG can be abnormal even in the pre-vitiliform stage. The cases like this, where we have one eye vitiliform disorder deposit or other eye atrophic patch, may sometimes create confusion, and EOG can be of some help to further confirm our diagnosis. This is a 7-year-old boy, which 2020 in the right eye and 2040 in the left eye, and no family history of any significant ocular illness. And we can see the right eye looks clinically normal, but left eye, there is a egg yolk like deposit at the central macula that shows by bright hyperautofluorescence and homogeneous subretinal deposit here. Left eye is quite characteristic of best vitiliform macular dystrophy. What about right eye? Now there comes the role of EOG. Again, we see that though clinically it looks normal, but EOG, again, there is stunted light rise, confirming that the right eye also is affected, and probably in a pre-vitiliform stage. The mother has a subnormal EOG recording, as we can see here, and sometimes the carriers can have a normal, carriers can be detected well with EOG if we don't have access to the genetic analysis. The first time when we come across this disease, this is difficult to diagnose. We have bilateral atrophic patch at the macula. One, it's circular in one side and platyhelminth-like in the other side. So the EOG, if we see, there is no the stunted light rise and quite confirmatory of best disease. Now, this is the case where EOG helps you for the first time, but thereafter the autofluorescence pattern and the pattern of bilaterally symmetrical disease and with good visual acuity helps you diagnose this condition that it's probably a best disease going to the end stage. This is the 19-year-old guy who has very minimal vision in very minimally affected symptom with a visual acuity of 20/25, and there is no bit cell, was diagnosed as a case of some form of posterior uveitis as the Mantu was 30 to 30 millimeter. But if you see, look at the autofluorescence, these deposits showed very bright hyper autofluorescence, and the ERG is, as we can see here, showed the stunted scotopic BUF, and EOG there is no light rise. So this is quite characteristic of autosomal recessive bestrophinopathy, which usually shows bilateral symmetrical non-inflammatory hyper autofluorescence, not hypo autofluorescent deposits deposited their course and deposited in a honeycomb pattern over the mid peripheries posterior pole, and EOG ERG both are abnormal. EOG is more affected than the ERG. It has an autosomal recessive inheritance, and quite usually we see neurosensory detachment. Quite often we see neurosensory detachment with intraretinal cystic space. The prognosis is usually good. 56-year-old female with right eye morphologically normal, but left eye had a vitelline deposit. The visual acuity was 20/20. So whenever we come across a lesion where lesion size is big, vitelline in nature, and but visual acuity is disproportionately good, one thinks of vitelliform dystrophies. This the OCT, as we can see, there is homogeneous hyper-reflective material, and ERG, full-field ERG and EOG are normal, quite characteristic of adult onset vitelliform macular dystrophy, and which is characterized by good visual acuity at the presentation, and sometimes can be mistaken for CSCR with subretinal fibrin or choroidal neovascular membrane. The ERG and EOG are normal, indicating that this disease probably has a focal pathology than the panretinal pathology that we see in best vitelliform macular dystrophy. So usually over the period of time, the deposits disintegrate, leaving behind a foveal thinning. So I end with this case, and thank you all for the opportunity.
Thank you very much, Tapas, for a very interesting talk and showing us the various presentations of Best dystrophy and the EOG findings as well. We'll have some questions discussion at the end. I now invite, I'll be starting the panel discussion. I invite our panelists, Dr. Poornachandra, faculty at Narayan Nethralaya with a special interest in electrodiagnostics, Dr. Simaranjan Singh from faculty at PGI Chandigarh Advanced Eye Center, and Dr. Sumita Agarkar, Deputy Director of Pediatric Ophthalmology in Shankar Nethralaya. So let me start with a question on the first talk to Dr. Coupland. Dr. Coupland, are you there?
Yes, I'm here.
Yes. In most studies on HCQ toxicity, the exclusion criteria are patients with any other retinal pathology, because it's always assumed that it gets aggravated if the patient is on HCQ. So what would your recommendation be for a patient who already has macular degeneration, diabetic retinopathy? How would you interpret the multifocal ERG for that patient?
Well, patients with diabetic retinopathy, are a significant issue because the entire retina is affected, and I think that they're probably the most difficult cases in which to determine what you think is an abnormality. We have collected some, no, I won't call it normative data, but we have collected some data from patients who have diabetic retinopathy and looked at that over time, and there are differences, though, absolutely, as you well point out, between them and patients that don't have diabetic retinopathy. And I think that this is something that needs addressing. We've got a small cohort of patients with diabetic retinopathy who are on long-term plaque retinal therapy, and there are changes, but they are different. They are different. You're absolutely right.
Now, may I ask Simar? Simar is probably one of the few faculty here who belongs to a multi-specialty hospital and probably gets a lot of patients for screening prior to initiation of HCQ Toxicity. What are your guidelines that are more applicable maybe here, or do we follow the same American Academy guidelines?
Yeah, thank you. Thank you for the question, ma'am. Thank you for having me here. So we do get a lot of referrals from our rheumatology and the dermatology colleagues before the initiation. And what we follow here, basically, I think we don't have any specific Indian guidelines. We do follow the West, but we do get an autofluorescence and a spectral domain OCT done at the baseline. And we do get 24, now we have shifted to 24-2 visual field instead of the 10-2 that we used to get earlier. We do not get multifocal ERG done as a routine for the initial screening. But yes, definitely when we are in doubt of any kind of toxicity, it does come on as an add-on test to substantiate or negate that. And as far as the follow-up is concerned, we prefer to follow these patients yearly instead of the recommendation that after starting, you can give them a 5-year term and then they come back, because that way the patient gets into the habit of getting it screened every year, as these drugs usually continue for a longer period of time.
If you have a patient with macular degeneration, are you going to speak to the rheumatologist and say, look at an alternative, or?
Yes. For our personal preference is yes, that we should look at an alternative, since the patient already has some form of compromise, and anything that can potentially add to that, it would not be recommended from our side. But I'm not sure if there are any guidelines for this.
Thank you, Dr. Simar. We'll go to the next talk, and that it's a very nice overview of pediatric electrophysiology by Dr. Rupak. I just asked Dr. Sumita a question. When would you send a child for ERG from your practice, assuming there's nothing straightforward in the fundus?
My most frequent indication for ordering an ERG is if I cannot explain vision loss in presence of either a normal fundus, or if the child has nystagmus with poor vision, and children who have history of consanguinity along with clinical features like nystagmus or another sibling affected, or poor vision which cannot be explained based on clinical findings. I would definitely ask for an ERG. The most common pick from ERG has been children who are myopic, who are moderately visually impaired, and often can have, say, between age 5 to 10, they often can have almost normal looking retinas, and still their vision does not improve, say, beyond 624 or 618. I would definitely get a color vision and ERG done for them.
Thank you. Now, there has been a question from the other panelists, and I request Dr. Tony Robson if he is there to take that. On, is there any abbreviated protocol for children Dr. Tony, are you there?
So there's no ISCEV. Can you hear me?
Yes, because I saw something in the chat box. I'm not sure if the audience could see it. So maybe.
So there's no ISCEV standard abbreviated protocol, although that was considered, but I think that'll be unlikely in the foreseeable future. However, certainly in Moorfields, we do use a shortened protocol for children. Children will not tolerate an ISCEV standard protocol unless they are, 8 years or older, or perhaps very occasionally in younger children. So in Moorfields, we tend to use skin electrodes on children under 5 years old. We always use 2 staff or 2 technicians to test the child. And we really concentrate on the responses that give us the most clinical information. So the photopic flicker ERG and the single flash cone ERG to assess cone system function, and a scotopic ERG to assess rod system function. And we often perform that scotopic ERG after only 5 minutes dark adaptation, because that's usually sufficient to give an indication of how well the rod system is working. If children cooperate and that they can comply with testing, we will extend the period of dark adaptation. So we tend to perform the test systematically, but starting with that basic 3-response protocol.
Dr. Holder, are you there?
Yes.
Yes. I have a question for you. Now, if one does a ERG under general anesthesia in a child, what particular pattern would prompt you to repeat it when the child is older and able to cooperate?
I'm not in favor of doing ERGs on children under general anesthesia at all. Most of the questions can be answered using the protocols that Tony's just described, which I set up at Moorfields when I was the head of that department, and we would always prefer to do the ERG under natural conditions rather than under general anesthesia. The dangers of interpretation because of wave suppression by the anesthetic, I find too great. I mean, if the child is being given a GA for an EUA for some other reason, okay, take advantage to see if the retina is functioning. But I don't think you can get the diagnostic accuracy that you would like.
Thank you, Dr. Holder. Dr. Rupa, one question for you. What would be your choice of investigation if you suspect a child is malingering?
Yeah, first of all, you have to retest them. That's very important, We really, today also we had a child who was refusing to say beyond even light perception. So I think testing them with a very patient mode will definitely give you whether they're malingering or not. And of course, you have to watch their actions, Sometimes you'll come to know. And the best thing is to do BEP onset, offset. That's what they're seeing. That's the best way of identifying whether the child is malingering or not. Because the child doesn't know when it gets off, whether it's there or not. Probably it might try to close the eye or something like that when the checkboards are coming up. So that's one of the best indicator for malingering children. And even in nystagmus also. Onset, offset, BEPs.
Thank you. We'll go to the next talk, Dr. Vishwanathan. There have been a few articles comparing PhNR and OCT in assessing glaucoma progression, where we know PhNR is quite sensitive in early detection of glaucoma. How does it compare with OCT in detecting progression?
As far as glaucoma is concerned, based on what's out there in the literature, the comparison of OCT and PhNR is, the relationship is about the same as the pattern ERG and the, I'm just trying to think back from the published literature. It does correlate in the initial stages, but then when it gets to the later stages, the correlation is No, it's the other way. In the initial stages, there is more variability, and it's in the more advanced stages that the correlation is much better. And where a lot of the data is missing is in the very early stages. So with the clinical classification of less than 6 dB being mild, actually there is quite a lot of variability in that range in terms of the correlation between the two.
Yeah, and regarding the use
and
of
also a part of it, in specifically in glaucoma, it could be that some of the earliest changes that occur in glaucoma, based on a lot of laboratory histopathological studies, are a modification of the glial architecture, glial proliferation and remodeling. And so some of the early PhNR changes could be reflective of simply the alteration in the glia and how they are actually siphoning the current even before you have a major structural damage to the axons.
And coming to vascular retinopathies, how would PhNR compare with the multifocal ERG or the pattern ERG? We know the P50 is kind of used as a predictor for visual outcome in ischemia and central retinal vein occlusions. How would PhNR compare?
The PhNR, this is based on a series of studies that came from several groups in Japan. They were looking to see what aspect of the flash ERG, whether the A wave or the B wave or the PhNR, how much it was reduced relative to normal. And based on that, they tried to make the prediction of visual recovery. And what they find is in cases where there is a good visual recovery, the PhNR is also recovering after treatment, whether it's in a natural course or with treatment. However, in cases where the vision does not recover, the B wave recovers, but the PhNR does not fully recover. So from a prognosis perspective, those studies are suggesting that PhNR might be better than the B wave, but PhNR is reduced, basically. Every time your B wave is going to be reduced, your PhNR is going to be reduced. It's more the magnitude of the reduction is a prognosticator. That's the suggestion from those studies.
Thank you, Dr. Suresh. And just have a couple of quick questions for the next topic on electro-oculogram, the very nice talk by Dr. Tapas. Dr. Poornachandra, we've always been taught that if you have a normal ERG, then the EOG, abnormal EOG is more significant. That's what's been kind of drilled into us over the years. Is it still there? Do you have to have a normal ERG, or do you have to do an ERG to get an abnormal EOG? How do you interpret that?
So thank you for having me here, and thank you, ma'am, for that question. Of course, my answer is yes. Always make sure that your photoreceptors are functioning normally before you interpret your EOG, because to generate this transepithelial potential, you need to have an intact photoreceptor system. Then only the RP, all those chloride channel shift, those things can happen. So definitely, I would like to do a full-field ERG before I interpret an EOG.
Yeah, thank you. Tapas, what are the tips to record an EOG in a patient with poor fixation?
It's really difficult. So this is a test where you need a lot of cooperation from the subject. And just the way is to keep on encouraging him and giving the subject adequate rest in between. That's all. Tips from my side, but sometimes those poor fixation I usually struggle.
Yeah, there was an interesting article where someone did the EOG on the parent when the child had a typical fundus picture, and the abnormal light rise was what clinched the diagnosis. So I think that's another thing you could do if you're not able to do it in the child itself. Dr. Tony Robson, I have a question for you, more of a technical one. when there is very poor vision in one eye, or say the eye is non-functional, we know there's an interaction of EOG between the two eyes. So how do you minimize that? Or Dr. Coupland, either Dr. Coupland or Dr. Robson, anyone?
So I guess, if you suspected that, you could always test monocularly, I suppose, although it would be a little bit tedious for the patient. But yeah, I guess there is a little bit of interaction, but in the context of disorders where the EOG is useful, it's probably not such an important factor.
Yeah, thank you. So
can I comment on that, please?
Yes, please. Yes, Dr.
It's really not an issue, because if you think about the disorders where it's unilaterally abnormal for the EOG, such as Azure, which it's really quite important to make the diagnosis, you can get reduced EOG in the Azure eye and a normal EOG in the other eye. It's not an issue.
So, so thank you to all the speakers and panelists for wonderful talks and nice inputs to all the questions that were posed to you. I'll now end the session and hand it over to Parveen. Thank you all for joining.
Thank you.
Thank you.
Thank you.
Thanks to all the speakers for the last session for a great moderation and interaction. I hand the next session over to Ramya and Jeff to take us through the technical aspects of recording all these electrophysiological tests. Over to you, Ramya. Jeff?
Hi, Parveen, waiting for Ramya.
Yeah. We can start with your talk.
First topic we'll cover in this session is recording artifacts that occur in ERG and VEP tests. As a quick overview, we'll cover what are the typical artifacts, what do they look like, what are their primary causes, how to prevent or minimize them, and how to remove their effects. Typical or most typical artifacts we experience in these types of tests are broken into 4 categories in this talk: line and other machine-generated electrical noise, blinks and other large body movements, excessive frequency, higher frequency biological noise, and slight eye twitches and movements, which tend to be the most difficult to prevent and deal with. First, line and other machine-generated electrical noise. As shown in these pictures, this tends to be sinusoidal in characteristics, so it's relatively easy to identify, even when mixed with some amount of biological noise, as shown here. Depending on where in the world you are, you'll have either 50 hertz or 60 hertz frequency power being provided to your system, so you'll have either 20 or 16.7 millisecond peak-to-peak characteristics of the line noise itself. Causes and ways to prevent this type of noise are shown over on the right-hand side. So poor cable and device isolation management. In this picture, we show cables that are wrapped together, touching metal. We try to avoid that, as shown in the picture to the right. Use of power strips. Power strips, when they have multiple pieces of electrical equipment plugged into them, can actually transfer electrical noise from one to the other. So very simple solution is to use a grounded wall outlet. Frayed or cracked electrical cables. Short answer is don't use them, don't try and repair them, use new electrode cables. And finally, poor or mismatched impedance, which is the electrical connection between the electrode and the patient themselves. Modern day software and amplifiers very quickly show you where you are. In diagnosis systems, we recommend using below 5,000 ohms or 5K ohms for all of the electrodes and keeping the electrodes within 2 to 3K ohms of each other. Second, blinks and other large eye and body movements. So this shows up in an ERG graph as a signal that goes quite high, or it could go quite low. This is hundreds of microvolts, if not over a millivolt, when a blink occurs or a large body movement. So it's easy to identify. You can see it quite quickly. Software also easily identifies the artifact and will remove it. Still, there are remnants of blink artifacts that oftentimes are found and left in the recordings, and so working to minimize the amount of blinks that a patient does during a test is a valuable thing to do. So causes of excessive blinking, irritated dry eyes, tired patient, bright lights, sneezing, large body movements, all of these can create more blinks than we would want to have during a test. So ways to prevent these types of problems include calm eyes, keeping them moist, properly positioning the electrodes on or near the eye is also important, comfortable patient position, room temperature, humidity, airflow, properly designed protocols for luminance, frequency, and other parameters, and then giving the patient breaks during the test itself. All will help minimize this, along with software strategies that will remove the blink artifacts that do occur. Third, excessive higher frequency biological noise. So this is naturally occurring to a certain extent. What we want to do is minimize larger biological noise that can happen, and we show some larger biological noise here that is larger than plus or minus 10 and certainly larger than plus or minus 20 microvolts. Typically, we recommend people using our equipment to try to keep this within plus or minus 10 microvolts, which is usually possible. So causes, again, poor impedance can cause this type of noise. The patient clenching their jaw or having a strained neck during the test, so patient position becomes important. And then finally, electrode movement during the test. It doesn't happen often, but it can happen from an improperly affixed skin electrode, not enough tape, for example, sweaty skin, and then patient movement, pediatric cases, or accidentally bumping cables in the dark. Ways to prevent, again, keeping impedances below 5K ohms, keeping the patient's eyes moist, proper skin preparation, properly positioning the electrodes, and good electrodes and equipment. Relaxed patient certainly is important, and then a well-trained and observant person conducting the test using sufficient tape and techniques to set up the electrodes, comfortable room temperature, and then observing the patient and the signals being recorded during the test. Finally, in my opinion, most difficult artifact to prevent and to deal with are slight eye twitches and movements. So first I'll show a normal trace where we see a clean A wave, B wave, and PhNR response that come from primarily the photoreceptors, bipolar cells, ganglion cells, respectively. And then two recordings here that show eye artifacts where you have an A wave, a B wave, A wave and B wave, and then a large swing down and a large swing up. This is a muscle twitch that's happening that moves the electrode and creates an artifact that can severely impact the recording that we're doing. So cause, principally, these are small eyelid muscular light reflex artifacts that happen as a reaction to the light stimulus in an ERG. It's a natural lid muscle physiology, and it can and does happen with all electrode types to varying degrees. Secondarily, this can be in non-mydriatic testing. This can be a pupillary response component as well, and that's been published in the literature. So ways to prevent: stimulating recording monocularly can help reduce the muscle response in some cases. There's less light coming at the patient at any one point in time. Using the fellow eye as a reference can help. Relaxed patient, electrode choice to a certain extent, monopolar bearing Allens can help, and they're less susceptible to this, but they still will record muscle artifacts. And then advanced system options, which I cover on the next page. So in terms of advanced analytics, we do have this in our newer software where we do advanced sweep monitoring, selection, filtering, and signal alignment. This can be done in runtime or in post-analysis options where you can take signals that have very large artifacts, eye twitches that have happened in each of these cases, and this is a set of about 20 tests down here, processed through our software and these techniques, giving you waveforms that are useful, where you started with something which in my opinion was not useful and in some cases difficult actually to interpret and determine that there are energy artifacts coming from the muscles there. This lower right-hand curve with 20 tests actually has one test in the middle of it that had no eye artifacts, so the techniques had the ability to reduce or eliminate the amount of deviations that occur in recordings from the muscle artifacts and bring them back to what you would receive if you had a calm eye being recorded. So success. High quality recordings are possible just about anywhere with high quality equipment, good electrodes, well-designed protocols, well-trained personnel. proper patient instructions and a patient with calm eyes and body. All of these types of tests are possible. This is a test that we did last year at AIOC on the show floor amongst hundreds of people and dozens of pieces of equipment. These recordings were quite good, and it's possible to do that even on a trade show floor. Thank you.
Thank you, Jeff, for the wonderful talk. So as this session involves about the technical aspects of the recording, so we have seen about the artifacts now. So I'll be sharing my screen to discuss on troubleshooting in visual electrophysiology recording. Is my screen visible?
Yes.
Yes, Ramya.
Yeah, thank you. Hello everyone, myself Ramya. So I'm working as an optometrist in the electrophysiology clinic at Shankar Nethralaya. So I'll be discussing few case examples related to troubleshooting in visual electrophysiology. So I would like to thank Dr. Parveen Sen and the organizing committee for providing me an opportunity and my colleagues for helping me with the presentation. So what are the qualities of a good recording? So it should be reliable, repeatable, and also the waveform should be smooth. So one more thing is it should be comparable across visits. So that is also very important. So I'll be discussing the troubleshooting in the following aspects, which are patient factors, examiner factors, and other factors. So coming on to patient factors, so proper positioning of the patient is very important, as well as fixation, and the eye movements should be controlled unless and until we are doing electro-oculography test. And also the learning curve matters a lot, specific to the protocol multifocal ERG as well as electro-oculography. So this is the recording of one of a patient wherein the chin rest and the forehead rest was not kept properly by the patient, and because of which the dark adapted point not an ERG responses were reduced in the amplitudes. And this is the recording of the same patient wherein the fixation was not so proper. That is, you can see here the cornea is little on the downside. This ERG was recorded using Bahrain Allen electrode. And once the positioning as well as the centration was corrected, we can see here the amplitudes have improved a lot. And with respect to the eye movements, it can cause a large amount of noise if the patient is moving a lot, as you can see in this video. So this happens when a patient is having very poor fixation as well as very poor vision. So it is very important to repeat the recording many times unless we get a consistent report. And as Jeff informed in the previous talk, the facial and the neck muscles should not strain much, otherwise, especially in the VP recording, can cause excess noise. So, which you can see in this video. So the patient is opening the eyes wider, and this impedance line, which is yellow in color, has reduced once the patient sees properly. And this is a MFERG recording of a patient wherein the noisy waveforms were noted and the patient did not see properly. And once the patient was instructed and given repeated breaks in between, the responses improved without any noise. So coming on to the examiner factors. So plugging in of the electrodes appropriately is very important. So sometimes the examiner may mistakenly interchange the active and the reference, which may end up in a wrong recording, especially in a multifocal ERG setup, wherein we may not be able to see the waveforms until it is completed. But in case of an ERG, even immediately after the test, we can see it, but the machine has an option of inverting the results. So we can use that definitely. The other one is proper occlusion of the other eye, and this is specific to visual evoked potential test. So I would like to show a report of a child wherein the child had very poor vision in one eye and the other eye was normal. So this was the recording which was taken first. So you can see the waveforms are almost similar in the amplitudes, the right eye as well as the left eye, but though the latencies are not so proper. And when the test was repeated, making sure the other eye is properly uploaded, you can see the amplitude has very much reduced. So this was the report which was taken before, and this was the report which was taken after uploading the normal eye properly. So this is very, very important in case of flash VEP, because the intensity of the flash is too much, and if it is not closed properly, definitely some amount of light can go in and it can cause different results. So coming on to the last part of my talk, which are the other factors such as electrical noise and avoiding other larger instruments in the lab. Jeff has explained it extensively. So I'm just going to show only a small sample of it. So how the electrical noise will be and how it can be rectified. So this is the recording of a flash VEP, wherein you can see here, even though the impedance was within the normal limits, the yellow line was very much wavy, and it was rectified by switching off the larger instruments which was there lying in the ERG room. So we have to make sure that the electrical noise does not affect our recording, as well as mistakenly the examiner or the attender should not touch the patient's head while performing the procedure, because that can also cause external noise. So this is the summary slide with respect to ERG and multifocal ERG, and fixation is very important. If not, definitely there will be reduction in the amplitudes, as well as the forehead and the chin has to be placed appropriately in the against the Gansfield board for full-field ERG, and for the multifocal ERG in front of the monitor. So another thing is the forehead as well as the chin should be in the same plane. It should not be tilted. Otherwise, sometimes the amplitude can be reduced in one part of the waveform, say a positive peak. And with respect to the examiner factors, this was discussed already. So the connection of electrodes is very important, as well as the lubricating eye drops should be used whenever there is poor contact. And if it is not, if there is any bubble in between, in case of a binaural electrode, it's going to reduce the amplitudes. And as suggested by the manufacturer, the impedance should be within the acceptable limit. So otherwise, there will be noise in the waveform. So the other factors, definitely any recording should not have any electrical noise. So VEP, other factors other than ERG checklist, definitely the patient should be in a relaxed state, and definitely they should not stain the face and the neck muscles. And with respect to the flash as well as the pattern VEP, the other eye has to be properly uploaded. Otherwise, there will be overlapping of the results between the eyes. So thank you for watching this.
Excellent. Thank you, Ramya. Very, very good presentation on technical aspects of doing all of the electrophysiology tests. Next, Natalie will play, we have 3 videos that show demonstrations of setting up and conducting these tests. Natalie, if you could tee up the first one for us.
Let us see how to perform a full-field electroretinography according to ISCEV standards. We will be using diagnosis machine for demonstration purpose. Dilate the eyes fully and patch the eyes for 20 minutes. Give a dark adaptation of 20 minutes. Start the program. Select new test. Enter patient demographic details like patient name, date of birth, hospital ID and gender. Select protocol. For recording full-field electroretinography, After 20 minutes of dark adaptation, start recording in dim illumination. Red light can be used for examiner mobility. Assist the patient to the machine. Make sure patient is seated comfortably. Sterile precautions are to be followed. Clean the chin rest and headrest before the procedure. Sanitize the hand before the procedure. The earlobe is cleaned with cotton and new prep gel. Place the gold cup electrode with 1020 conductive paste. Secure with a tape. Remove the eye patch. Put a drop of topical anesthesia. With a drop of lubricating eye drops, insert the birenal electrode by asking the patient to look down. Check for centration. This is to be done under dim illumination. Check for impedance, it should be less than 5 kilo ohms. Adjust the height and make the patient sit comfortably. Instruct the patient to fixate at the central red target. Start recording scotopic responses based on ISCEV guidelines. After 10 minutes of light adaptation, start recording photopic responses. Once the procedure is over, remove the electrodes, clean the gold cup electrode and rinse with water. Clean the contact lens electrode with 2% bacillocid and rinse with water. This is a presentation by Elite School of Optometry and Sankara Nethralaya. Thank you for watching.
Let us see how to record visual evoked potential procedure. These are the materials required for recording the procedure: 1020 conductive paste, neoprep gel, gold cup electrode and alcohol. We will be using diagnosis machine for the. Let us start the program. Select new test. Enter the patient details such as family name, first name, date of birth, hospital number and gender. Select appropriate from the instrument. Make sure the sterile precautions are taken, such as cleaning the forehead rest as well as the chin rest of the instrument before starting the procedure, as well as sterilize your hands. For the reference electrode placement, it will be placed on the forehead. As a skin preparation, it has to be cleaned with neoprep gel. Clean with alcohol swab. Place the 1020 paste on the skin as well as on the gold cup for better conductivity. Make sure it does not fall in front of the patient's head. Secure the electrode with the Medi-tape. Next, ground electrode placement. Similar procedure will be followed and the electrode will be placed at the CZ position. Next comes the active electrode placement, which will be placed on the occipital cortex. So finally we have 3 electrodes, forehead, midline and on the occipital scalp. Before starting the procedure, let us check the impedance, which should be less than 5 kilo ohms. Make sure the patient is seated properly so that the neck and facial muscles does not cause any strain. Perform a monocular recording. The stimulation can be started under dim illumination. So at least 3 recordings are required. Make sure you repeat the recordings so that we get a consistent response. Once the other eye is also completed, let us proceed with the pattern VEP. Patient has to at least see the central fixation target to proceed with the pattern VEP. We have 2 check sizes. Number 1 is the 1 degree check size, which is shown in the diagram here. Similar to flash VEP recording, we need to repeat so that we get a consistent response. And this is the 0.25 degree check size. And P100 will be recorded here. Repeat the same for the other eye and clean the electrodes and rinse with water. Thank you for watching this video, which is an Elite School of Optometry and Shankar Nethralaya presentation. Let us see how to perform electro-oculography. These are the materials required for the recording: 1020 conductive paste, neoprep gel, gold cup electrodes, and we will be using diagnosis machine for the demo purpose. Start the program. Enter patient details such as family name, first name, date of birth, hospital number, and gender. Make sure the forehead rest and the chin rest are cleaned appropriately. As well as sterilize your hands before starting the procedure. The pupils have to be dilated before the procedure. Make sure the pupils are dilated before the procedure. The ground electrode should be placed on the forehead by cleaning with neoprep gel and using gold cup electrode with a conductive paste. Place the conductive paste on the skin as well as on the gold cup electrode and make sure that it does not fall in front of the patient's head. Secure with a tape. The active and the reference electrodes are placed on the lateral and medial canthi of both the eyes. Plug in the electrodes appropriately. Provide demo to the patient and make sure that the patient uses their eyes to follow the light and not the head. After the completion of the procedure, the ratio of the light peak to the dark trough will give us the Ardens ratio. Once the test is completed, just remove the gold cup electrodes and rinse with water. Thank you for watching this video. This is a Elite School of Optometry, Shankar Nethralaya presentation. I thank the optometrist at our clinic for making this video possible, as well as Jeff for providing comments to make it possible. Thank you, Jeff.
Thank you, Ramya. And thank you for your presentation as well.
So in this third session, we had technical aspects of the recording. So Jeff has covered almost the single possible detail of it, and I have just tried to show those in case examples. So I just have a question for you, Jeff, which I have just put in the chat. Just a minute. Yeah. How to differentiate between electrical noise as well as the noise caused by the patient if both are present in the same recording?
That's a very good question. Generally, the thing that we look for is the electrical noise first, which tends to have a sinusoidal shape to it. When it's mixed with some biological noise, it is a little bit more difficult sometimes to see that you have electrical line noise. But generally, if you see a regularity, even if there are some bumps to it, that has spacing similar to what I discussed in my talk, you can have a good suspicion that you have some amount of line noise that you would want to try to find a way to reduce in your recording.
Yeah, thank you. Okay, you have a question for me?
I have a question for you, actually, also, Ramya, if I could ask that. So at Sankara Nethralaya, if I remember correctly, you do 4,000, maybe over 4,000 electrophysiology tests every year, which is very high volume, and you have a very large team of optometrists who do the tests. Can you talk a little bit about the training program that you use at SN to train people to do electrophysiology tests?
Okay, so what we do is mainly at our clinic, optometrists only will do the recording. So there is no special requirement to be an ocular electrophysiologist in our clinic. So what we do is the seniors in that clinic will train the people based on the protocol. So we have a template for it actually. So we just give them reading materials, and they have to keep updated on the ISCEV standards and also the clinical protocols as well, and then we give them a time for it. And once that is done, we just give them observation for almost a month. So say about 50 hours or more than that, and then as a cutoff, they have to see at least 100 cases. And individually, they have to do 10 cases under the supervision of the senior. So once everything is completed, we conduct a like a Rubik's kind of a like report, and we have a checklist for it. So starting from like telling the purpose to the patient, making the patient seated properly, and then choosing the appropriate electrode, and also making the interpretation appropriately as well as the documentation. So once the supervisor feels that this candidate is good for making like individual posting, then we post them individually, and then they get turns in it. So we don't have exactly a proper protocol, but still we follow this.
You have many steps to the process, which that is very helpful. Not all hospitals and clinics have implemented such a program, so I think that's very good.
Yeah, thank you.
Thank you.
Thank you. PK ma'am?
We have run a little bit late. If I could ask two requests. Parveen, if you could join us. And before we close out, Dr. Graham Holder, if you're still with us, if you could join us. Graham had asked if he could make a comment just before we close. So there's Graham. Hi, Graham.
Hi, just a couple of very brief advisory comments in relation to techniques. It's very nice to see the technical side of things being addressed. And of course, different electrodes have different problems. Those people who use DTL electrodes, and I now use those, can get very good recordings, but if the electrode is positioned initially at the lower limbus of the cornea, and during the recording it drops via blinking into the lower fornix, you get a 25% amplitude reduction. So always check the electrode position at the end of the recording to make sure it's the same as at the beginning of the recording. Don't just assume that it will maintain a stable position. The second thing relates to the use of flash VEPs in a potentially blind child. Not all equipment, when it flashes, is silent. Particularly the old Grass PS22s makes a big loud crack every time the light goes off. And that can give you an auditory evoked potential, which can be picked up through the reference electrode and mistaken for a VEP. And the way to recognize that is to repeat the test with the stimulus facing away from the child, but held at the same distance from the child. So if it's auditory, it will not change. If it's visual, it will disappear when the light is facing away. Just a couple of practical points.
Very good. Excellent.
Thank you.
Thank you, Graham. Parveen, we'll turn things over to you.
Thank you, Jeff, and thank you, Ramya, for a very excellent session. And I think the videos were made largely for the benefit of the audience who would really want to practice these techniques and bring them in their regular retina clinics. So with that, I think we conclude for the day. We are just a few minutes over time and apologize for that, but I think we did have some good discussions, did not want to curtail them prematurely. So I thank all my speakers and panelists and the moderators for the day. And I hope we all learned a lot from the discussions today. And I hope to see you all tomorrow as well. We meet at 6 o'clock Indian Standard Time tomorrow. And till then, have a good day. Thank you so much.
Thank you.
So a very good evening, everyone. We are live and we are beginning the second day of the Electrophysiology Masterclass 2021. I hope we are able to keep this journey of learning as eventful and interesting as it was yesterday. So on the second day of the day, we have two sessions with us. The first is going to be on electrophysiology in neuro-ophthalmology, and the second session is on the expanded role of electrophysiology in other conditions like vascular retinopathy and inflammatory and autoimmune disorders. So in the first session, I have very distinguished speakers and panelists with me. I'll introduce my speakers and panelists, and my first speaker is Dr. Neha Goyal. She's a senior consultant and vitreoretina surgeon, and she's a founder and director of the TetraView Super Speciality Hospital Eye Center in New Delhi. Our second speaker is Dr. Graham Holder, who's a professor, National University of Singapore and National University Hospital, Singapore. Other than that, we are all very familiar with him, and he needs no introduction really. Welcome, Dr. Graham. Third speaker is going to be Dr. Alki Laisis. He's clinical professor of ophthalmology, director of electrophysiology services, University of Pittsburgh School of Medicine. Welcome, Dr. Alki. And with me on the panel are Dr. Shikha Basi, who's a close friend, and she's a deputy director of the Neuro-Ophthal Services in Shankar Nethralaya. Dr. Rashmin is the managing director, Foresight Worldwide, consultant and director, Neuro-Ophthalmology Center for Sight, Hyderabad, vice president of the Indian Neuro-Ophthalmology Society, and above all, he's an SN alumnus, and we had some good times together. So with that, I request Dr. Neha Goyal to start her first talk, and she talks to us on the VEP technique and its applications. Over to you, Neha.
Good evening. First of all, I'd like to thank Dr. Parveen and the entire organizing team for giving me this opportunity. And I'll be talking about VEP, the technique and clinical applications. So as we know, VEP is part of the 5 standard ISCEV clinical tests, and these tests utilize a primarily vertical pathway of neural visual information flow. The VEP is basically cerebral cortical electroencephalographic signals which have been recorded at the scalp near the occipital cortex using cutaneous electrodes. What we use clinically are the transient VEP responses. These can be the pattern reversal VEP, the pattern onset offset VEP, or the flash VEP, depending on the type of stimulus which has been used. Now, before starting, I'd like to emphasize one point, that the central 10-degree of the visual field is represented by a disproportionately large caudal part of the striate cortex. This portion of the visual cortex is closest to the electrodes placed at the scalp for VEP recording. Therefore, the VEP is dominated by the central visual field, and this is important to remember whenever we interpret the test. Now, starting with the electrodes, the standard silver-silver chloride or the gold-is EEG electrodes are placed on the scalp. The landmarks used are the nasion and the inion, the vertex, which is a point midway. The active electrode, the occipital, is about 10% above the inion. The reference electrode comes about 30% above the nasion, which is corresponding to the forehead, and the ground electrode can be at the earlobe, the vertex, or the mastoid. This is how the electrodes are in position. The impedance should be less than 5 kilo ohms. Now, this single channel VEP, it can only detect pre-chiasmal disease. If chiasmal or retrochiasmal disease is suspected, then you need a multi-channel VEP where you need 2 lateral active electrodes. This can be used to demonstrate the chiasmal misrouting, as in albinism, or retrochiasmal dysfunctions which cause a uncrossed asymmetry. The stimulus used for a flash VEP comes from a handheld stroboscope or a Ganz field and is a standard 5 millisecond flash subtending an angle of 20 degrees, about 3 candela second per meter square. The pattern stimuli are defined by the visual angle subtended by the side of a single check in degrees or minutes of an arc at the eye. So these can be large, that is 60 minutes, or small, which is 15 minutes. Now, this is what the screen looks like. There should be a high contrast between the black and white squares. The number of black and white checks should always be equal on the screen, and there should be no overall change in the luminance of the screen, the mean being around 50 candela per meter square. Now, this luminance artifact is more common with LCD as opposed to a cathode ray tube. And a variation from the center to the periphery up to 30 degrees is acceptable. This is as per the standards given out by the ISCEV. A reversal rate of around 2 reversals per second should be there, and this should be mentioned as well. Now, coming to the patient preparation, the patient should be undilated. For the pattern VEP, the refraction should be in place and a viewing distance of around 50 to 150 centimeter. The fixation is the red cross at the center, as I showed over here, this one. A monoocular recording is preferred in a dim or an ordinary room light. At least 2 replications of each stimulus should be done to confirm the responses, and these should be displayed as well. Now, as per the ISCEV standards, at least one standard protocol should be included in every clinical VEP recording session. So this can be either a pattern reversal VEP elicited by checkerboard stimuli with large or small checks, a pattern onset offset VEP elicited by checkerboard stimuli of large or small checks, and a flash VEP elicited by a brief luminance instrument of flash which obtains an angle of at least 20 degrees. Now, coming to the measurements, the VEP tracing is presented as positive upward in the ophthalmic literature, while the reverse is shown in the neurological literature. Therefore, any VEP waveform should have the polarity clearly labeled. As we know, the anatomical differences in the folding patterns of the gyri and sulci are responsible for marked variability in VEP among individuals. This is more in amplitude as opposed to the time to peak, which makes this a better and a more consistent clinical measure. Now let's see some of the typical waveforms. This is a pattern reversal VEP. The amplitude here you can see is measured from the preceding negative peak N75 to the peak of P100. The P100 peak time is the time from the stimulus onset to the peak of the component. This was earlier called the implicit or the latency, but the time to peak is a better description. The P100 peak time is affected by non-pathophysiological parameters such as the pattern size, contrast, mean luminance, the signal filtering, patient age, refractive error, so on and so forth. This is what a typical recording from our laboratory looks like. The pattern onset or offset VEP has 3 waves, the positive C1 and C3 and the negative C2, which have latencies of approximately 75, 125 and 150 milliseconds respectively. These are measured again from the stimulus onset. Coming to the flash VEP, this consists of a series of positive and negative components. Of these, the most prominent is the P2, which peaks around 100 to 120 milliseconds from the stimulus onset. This is what a flash VEP looks like. Now, what we measure clinically are the transient VEPs. The steady state VEP is basically a sinusoidal waveform where you don't see the positive and negative waves. And this happens at a stimulus rate of greater than 5 Hertz when the brain doesn't have time to recover in between the stimuli. So to summarize, in a VEP recording, a minimum of 2 recordings should be displayed with the positive upwards. Other things that should be mentioned are the location of the electrodes, the stimulus parameters, the filter settings, the time to peak, and the amplitude measurements. Now, interpretation should include relation to the normative data, comparison between the 2 eyes, or with previous records if those are available. So before we go to the clinical applications, just to revise the caveats of VEP, as we saw, it is dominated by the central visual field. Hence, macular disease can give marked VEP delays, and this should be excluded beforehand. An impaired VEP is anatomically non-specific because it can be produced anywhere by a deficit in the visual pathway at the retina, the optic nerve, or the brain. And flash and pattern VEP using a single channel detect prechiasmal disease only. So with this in mind, this is where the VEP fits into the algorithm given by Professor Graham Holder, which we can use in accordance with pattern and full-field ERG to delineate whether the pathology is non-organic, whether it's a neuropathy, whether it's a retinopathy, which can again be generalized, or a maculopathy. Now, coming to the pattern and flash VEP, the pattern VEP is less variable in waveform and timing. Hence, it is preferable to a flash VEP whenever possible. However, it can be impaired by deliberately poor fixation, by defocusing, or by conscious suppression. Hence, a flash VP is more useful when there are poor optics or poor cooperation from the patient, malingering in children, or when there is poor vision. So while there is marked inter-individual variability in a flash VP, but the interocular symmetries are similar to a pattern VP. So the clinical applications of VP are in suspected neuropathies. Like, let's look at some clinical examples like this male 40-year-old who had a black spot in his left eye since 3 days, noted 6/6 earlier, came to us with Snellen of 624, and these are the visual fields of the patient. So with the clinical suspicion of optic neuritis, pattern VEP was done, and you can see that there are delays in the right eye as well. This is post-therapy following the ONTT protocol where there was recovery on the visual field. So in acute optic neuritis, there's usually a poorly recordable pattern VEP. With recovery of vision, the waveform starts to appear and the amplitude may return to normal earlier than the time to peak. The flash VEP remains and recovers faster than the pattern VEP. And whereas in acute optic neuritis, it may not help much, but it definitely helps to pick up patients with subclinical optic nerve involvement in diseases such as multiple sclerosis. Another patient showing acute optic neuritis, right more than left, and a poorly recordable waveform, where then the flash VEP was done. And this is post-therapy. You can see that the waveform has now appeared, but the time to peak is still prolonged. This was a patient with decreased vision in the inferior half of his eye since 2 days in his right eye, and clinically looked at like an acute ischemic optic neuropathy. And the pattern VP, as you can see, shows both amplitude as well as time to peak delays. So severe abnormalities can be observed when AION is associated with giant cell arthritis. In non-arthritic AION, the typical abnormality is amplitude reduction and less of a latency shift. Now, this was a young female with history of tuberculosis, abortion due to venous thrombosis, and DVT, which was most likely a case of idiopathic intracranial hypertension. And these are her fields, and here you can see the PEP as well. So in idiopathic intracranial hypertension, the mean P100 latency can be prolonged. However, it is less sensitive than perimetry in follow-up of these patients. Now, this was a young male who came with decreased vision in one eye, even though he was 6/6, and VP delays were noted in both eyes, and retrospectively, he was found to be taking cyclosporin for skin disease. And yes, cyclosporin does cause isolated optic neuropathy, and VP has been recommended as a part of follow-up of patients receiving cyclosporin. So in addition to cyclosporin, other toxic optic neuropathies can be monitored using VP, such as ethambutol, chloroquine, and even some other anti-epileptic drugs. VP is also useful in picking up traumatic optic neuropathy or in prognosticating such cases, and in lesions of the occipital cortex. In addition, we clinically often use VP to assess the visual maturity in premature children or children with developmental delays or even normal infants, and also to indicate the potential of a diseased or an injured eye preoperatively or as the case might be. A word about sweep VEP. This is used to estimate visual acuity in infants and preverbal children. Multifocal VEP, which can be used for detecting visual field loss in glaucoma, and it helps to rule out malingering or non-organic causes. So to conclude, this talk reiterates that electrophysiological assessment is a specialized part of ophthalmic practice. And despite advances in imaging, electrophysiology provides us unique information leading to a definitive diagnosis in selected cases in accordance with other clinical and electrophysiological tests. Electrophysiological tests such as VP are also invaluable in monitoring diseases, in evaluating inherited diseases, and also in clinical trials of new drugs. Thank you for your patient hearing. And again, I thank the entire team for masterclass and for allowing me to be a part of it.
Thank you, Dr. Neha, for setting the tone of the session. So we have the basics and of VEP with us. With that, I invite Dr. Graham for his talk on application of PERG and VEP in optic nerve disorders. But we have another very interesting talk lined up for the day. So let's go to Dr. Alkiliasis. I invite you to give us the talk on VEP in albinism. So it is something which we haven't heard of very often here. So we would like to hear your experience and how do you go about it? Over to you, Dr. Alki.
Thank you very much for inviting me. Natalie's going to present my slides.
I'd like to thank the organisers for asking me to give this talk today. And today I'll be talking about visually evoked potentials in patients with albinism. I do not have any financial disclosures. We're all aware that albinism is a heterogeneous group of genetic disorders characterized by an absence or reduced melanin pigment in the eyes, skin, and hair. And the ocular features include severe hyperplasia, hyperpigmented fundus, nystagmus, and strabismus. And of course, misrouting of the retinal ganglion cells at the chiasm, resulting in an abnormal retinotopic representation of the visual cortex. On the right-hand side, you can see the phenotypic variation of patients with albinism, and hence where visually evoked potentials can help with the diagnosis. There are many imaging studies that demonstrate this abnormal retinotopic organization within the cortex. And here we have an imaging study where in a control subject, you can see stimulation of the nasal retina results in activation over the contralateral hemisphere. And likewise, stimulation of the temporal retina results in activation of the ipsilateral hemisphere. In a patient with albinism, we can see that stimulation of the nasal field results in activation of the contralateral hemisphere, while stimulation of the temporal retina results in activation over both the contralateral and ipsilateral hemispheres. It's not feasible to carry out imaging studies in everybody suspected with albinism, and this is where visually evoked potentials can help. In normal subjects, during full-field stimulation, we have equal activation of both the left and right hemisphere, and as a result, the visually evoked potential has the largest response at the midline and is symmetrical over the left and right hemispheres. In comparison, due to the misrouting observed in albinism, we have too many fibers crossing at the midline, and as a result, the visually evoked potential becomes asymmetrical. And it's this asymmetry in the visually evoked potential that enables us to identify chiasmal misrouting. When considering what stimulus to use to evoke the responses, we have a number of options. Although clinically we typically use pattern reversal visually evoked potentials to investigate macular pathway function, predominantly due to its known maturational time course and its well-defined stable morphology, we know that the responses can be degraded significantly in those patients with nystagmus. There's also the issue that the lateralization of the responses when you stimulate one hemisphere varies depending on the field size. With a large field size, the responses are paradoxical. So when you stimulate the left hemisphere, we would record the response over the right. And with a small field size, the lateralization is anatomical. And when you stimulate the left hemisphere, you pick up the response over the left hemisphere. In comparison, pattern onset responses are more robust in nystagmus and always have an anatomical lateralization. Flash VEPs can also be used. The morphology of the waveform can be complex, but they have the advantage they can be used in very young children and infants. In those small numbers of patients without nystagmus, we can use hemifield stimulation to investigate the crossing and not crossing pathways individually. This is a schematic of how nystagmus can confound the stimuli. On the left-hand side, we have pattern reversal, and the nystagmus is represented by the moving red spots. And what you can see is the nystagmus may result in not allowing the checkerboard to alternate from black to white. In comparison with the pattern appearance stimulus, you can see regardless of the eye position, the stimulus changes from black to gray or white to gray, which is a 50% change in contrast. This is a busy slide, but what it shows is the VEP findings in a group of 16 children with albinism but no nystagmus. And what can be seen reflected by the shaded areas are the VEP findings that did not reveal chiasmal misrouting. The absence of VEP evidence of chiasmal misrouting in some of these patients for some of the stimuli most probably reflects the maturational changes observed in the flash and pattern appearance VEPs. What is clear by the data is that when investigating chiasmal misrouting, a number of different stimulus modalities should be employed. Another reason why we may not always see VEP evidence of chiasmal misrouting is due to the normal orientation of the brain. In 80% of normal right-handed subjects, the left hemisphere has a greater gray matter volume and protrudes past and over the right hemisphere. And as a result, it may disrupt the normal symmetry of the VEP responses that we would expect. This is an example of how the orientation of the cortical dipole can affect the symmetry of the visually evoked potentials. Here you can see a right eye full field response for a pattern reversal stimulus. And what we see straight away is that over the left occiput, the responses are very degraded. And this was the case for the left and the right eye, suggesting a hemisphere problem. When we look at the right half field, we can see there's a well-defined IP100. And when we stimulate the left half field, there's also an IP100, indicating normal left and right half field function in this subject. And it's only when you superimpose the two half fields together, you can see that there's cancellation of the waveforms over the left occiput. And this is predominantly due to the symmetrical left half field response. These are the findings in a 6-year-old child with albinism. On the left-hand side, we can see a schematic of left eye stimulation. We use a large stimulus field, and as a result, the pattern reversal VEP responses have a paradoxical lateralization. So when we stimulate the left eye, too many fibers cross over to the right hemisphere, and we pick up the largest VEP amplitude over the left occiput, as can be seen here. When we stimulate the right eye, now too many fibers cross over to the left hemisphere, and the largest response is recorded over the right occiput. And it's this crossing of the largest response from one eye to the other and one hemisphere to the other that identifies the chiasmal misrouting and is given the term cross-day symmetry. These are the VEP findings in a 5-year-old child with albinism. And this slide shows the difference between paradoxical and anatomical lateralization in the same subject. On the left-hand side, we have the visually evoked potentials during pattern reversal stimulation. And due to the paradoxical lateralization, responses are recorded maximal over the hemisphere ipsilateral to the eye being stimulated. So when we stimulate the right eye, the responses are largest over the right occiput. And when we stimulate the left eye, the responses are larger over the left occiput. In comparison with pattern appearance, due to the anatomical lateralization, the maximal appearance VEP is recorded over the hemisphere contralateral to the eye being stimulated. So when we stimulate the right eye, the response is largest over the right occiput. And then when we stimulate the left eye, the response is recorded maximal over the left occiput. If we mathematically subtract the left from the right hemisphere, we end up with a subtraction waveform. And when we compare the subtraction waveform between the left and right eye, we can see they're almost mirror images. This slide shows the similarity of the flash VEPs in 3 children with albinism, aged 1, 3, and 4 years. And what we find is when we stimulate the right eye, the P2 component is larger over the left occiput, and when we stimulate the left eye, the amplitude is larger over the right occiput. And here we can see the subtraction waveform for 3 children, showing that cross-day symmetry for the P2 component. However, there's also an early negativity that seems to cross from one hemisphere to the other. This is another chart demonstrating a cross-day symmetry. These are the flash VPs, and when we stimulate the left eye, responses are larger over the right occiput, and when we stimulate the right eye, responses are larger over the left occiput. This child was found, however, to have achiasmia, which is a failure of the chiasm to develop. Therefore, caution should be taken when interpreting crossed asymmetries, as the cross asymmetry observed may in fact reflect crossing pathway dysfunction. And this is where, by using different stimulus modalities, the findings can be helpful in confirming whether there's too many fibers crossing, as in albinism, or too few, as in a chiasmal tumor or achiasmia. Once we've identified chiasmal misrouting, there's a number of ways we can report the findings. First, we can qualitatively just inspect the waveforms and describe differences from one hemisphere to the other. We can quantitatively measure the amplitude and latency of the components from one hemisphere compared to the other for each eye. And we can also carry out a statistical analysis using the Pearson correlation coefficient. The subtraction waveforms over a defined period are used to calculate the PCC, which is the covariance of the two variables divided by the product of their standard deviation. If we had subtraction waveforms that were identical to each other for each eye, indicating no asymmetry at all, there'd be a positive PCC of 1.0. In comparison, chiasmal misrouting results in subtraction waveforms that are mirror images of each other, and if they were 100% mirror images of each other, there'd be a negative PCC correlation of 1.0. So you can see how we can use the negative correlation to identify chiasmal misrouting. In summary, we can see that visually evoked potentials are able to identify chiasmal misrouting in albinism. And we can also see that different stimulus modalities are better at identifying this chiasmal misrouting at different age groups. The flash VEP is better for identifying misrouting in the younger children, while the pattern onset or pattern appearance visually evoked potentials are better at identifying the misrouting in the late teenagers and adults. And then just finally to add that not all crossed asymmetries are albinism, and we need to be aware of other asymmetries, such as those evoked by achiasmia or those in chiasmal tumors. Thank you.
So with that, I thank all my speakers for giving us wonderful talks as well as keeping the time. We still have about 15 minutes exactly for a good discussion. I will just begin with probably the basic question first. And Dr. Shikha, since you are a neuro-ophthalmologist and all these tests lead to the diagnosis of neuro-ophthalmic conditions, in what conditions do you think you would advise these electrophysiological tests when you are in the clinic? What are the conditions in which you use electrophysiology in your clinic? Shikha, you are muted. Can you unmute yourself?
I'm so sorry about this. Most of the conditions where I use electrophysiology in my clinic have already been elaborated so very well by Dr. Goel and Dr. Holder. In Dr. Holder's talk, what I realized is that he plays so beautifully with the combination of VEP and pattern ERG and multifocal ERG to get to the diagnosis. We do pretty much the same, but I realized where he is using pattern ERG along with VEP to get to the diagnosis, we are using OCT GCC thickness. He is, I'm like, we are not using N95 as much as the GCC thickness to get an idea about the GCC health. So in retrobulbar optic neuritis and in patients with functional visual loss, patients with traumatic optic neuropathy, where we need to kind of prognosticate and tell how well the patient might improve after the treatment. In all these cases, we use VEP. VEP is very useful. And the other thing that has already been elaborated is the use of multifocal ERG. There again, I combine MF ERG along with OCT to distinguish between a maculopathy from the optic neuropathy. But and these are the things where we're using electrophysiology in our clinic.
Thank you, Shikha. Yeah, Rashmin, you wanted to add something? Please go ahead. Dr. Rashmin? Okay. Yes, Rashmin, would you like to add something?
He's also muted.
In my practice, most important. No, I'm not muted. I think my internet is a little shaky.
Yeah. So could you repeat yourself?
Yeah. So in my practice, the important cases where I look at electrophysiology, most important thing is when we suspect a functional vision loss where we are not very sure that the patient has an optical dysfunction. Second, there are cases where you may not be able to clinically distinguish between optic nerve and retinal disorder, as Dr. Coupland mentioned. And third would be where you know that the patient might, the whole case might be taking a medico-legal turn. And one of the reasons would be traumatic optic neuropathy. In fact, can I ask a question to Dr. Neha? Parveen?
Yeah, sure. Please go ahead.
Dr. Well, wonderful talk and enjoyed as always. Just wanted to ask you one thing is that you mentioned about prognostication, use of VEP as a prognosticating tool in patients with traumatic optic neuropathy. What's your experience with that? And can you elaborate a little bit more?
So naturally it depends on the time to presentation, but usually if the patient presents within 24 to 48 hours, we do give, after ruling out any bony pathology, we do give a trial of high dose intravenous steroids for the inflammatory part of it. So there, it can be used to explain to the patient the interocular asymmetry can be shown, and also post the treatment sometimes the waveform becomes a bit better but the vision does not improve. So in those cases again it can be used more to show the patient. By a prognostic tool I meant more of explaining to the patient, though more I meant it pre-operatively, say for which we all use post-trauma if we have vitreous hemorrhage or retinal detachment or whatever, to prognosticate comparing with the other eye, and also like you very rightly mentioned for medico-legal purposes, because even if in the rare cases that you do deny surgery to these patients, you must have a flash VP.
So in a pure case of traumatic optic neuropathy, because I know there have been some papers some decades ago, does preservation or amplitude of VEP has any bearing on what would be the prognosis on traumatic optic neuropathy? Let's say 50% is preserved. Is it better than no VEP at all? Is there any such correlation that you have found in traumatic optic neuropathy?
No, to be honest, we haven't analyzed that, and neither have I come across any such paper. But there have been studies from AIIMS based on which we give the trial of the intravenous steroids initially after ruling out bony injury. But whether there is any correlation between the amplitude and the recovery, I cannot say. Perhaps Professor Holder can tell us if there's any such relation.
Dr. Graham, would you add on that?
Yeah,
Yes.
in my experience, it's not worth doing a VEP acutely. The only thing that you might be able to judge is if you have no VEP whatsoever, and there's no evidence on the MR that there's significant swelling or something which may cause conduction block temporarily, things are probably not going to be very good. But it's the follow-up that is most important, I think. In trauma cases, in the same way that with trauma of the globe, and I've had this discussion with Ferenc Kuhn on many occasions, that you deal with the trauma. You don't use the electrophysiology. It's not diagnostic. It's not going to give you prognosis. You deal with the trauma, you deal with it medically, and then you worry about the electrophysiology to demonstrate the function that's remaining afterwards. Because the electrophysiology is not going to affect the management. The management is going to be that which you do acute in an acute trauma. If there's any doubt as to the remaining function, then the electrophysiology will give you the truth as rather than what the patient is telling you as to what they may or may not be able to see.
Thank you for putting that in perspective, because I think that is one thing which we often break our heads on in the clinic. One more sensitive topic I will like to touch upon before I go into the other details. Rashmin, where do you weigh electrophysiology as compared to MRI? I know all of you depend a lot on MRI. Is there any situation where you would say that this is equally good or it is better? I think Rashmin, you're.
Parveen, I'm sorry, would you repeat?
Yeah. So as a neuro-ophthalmologist and neurologist, you depend on so much on imaging, especially the MRI. Is there any place where you think the electrophysiology helps you more than an MRI?
I'm sorry, my network is a little shaky. Are you saying VEP versus MRI for subclinical diseases?
Yes, that's right.
Yeah, I would rely for subclinical disease, like say what Dr. Neha mentioned about picking up subclinical optic neuritis and multiple sclerosis. Obviously, in the pre-MRI era, that was one of your tools to go. But I would rely more on MRI when you say subclinical disease or presence of multiple sclerosis versus electrophysiology.
Dr. Graham, in the same light, what would you think about the role of electrophysiology in the other eye, in predicting optic neuritis in the other eye? Does VEP help in any way?
Yeah, I mean, one of the things that's important, of course, is the clinical presentation. And if the juniors think that they're going to find every patient who's got an acute optic neuritis having a relative affluent pupillary defect, they won't, because there can be subclinic involvement of the other eye. So when they get a patient coming in through the emergency room who's got the symptoms of an acute optic neuritis and a normal pupillary response or lack of an afferent, they must consider the possibility the other eye is already involved. In terms of MRI versus VEP, one is structure, one is function. They go together. Not what you can't talk about one being good. It's like comparing an apple with an orange. They're different. One is telling you structure. I can give you many cases of patients, for example, with dysthyroid eye disease, and you've got optic nerves which look as if they may be compressed or they may not in the apex of the orbit. The patient is unreliable. You need electrophysiology to determine whether the structural changes are significant or not. Cases which we see probably once a week, where something comes in, they may have an optic neuropathy. The neuroradiologist says there's possible slight enhancement within the optic nerve. Is it significant or not? And we had a case which literally we're just working up at the moment, where the patient actually has azure, does not have an optic neuropathy at all, but there was minimal enhancement, which was said to be equivocal by the neuroradiologist. On the basis of that, the patient actually was given steroids, which probably might have helped at the azure anyway. And then it was only after, when symptoms got continually worse without actually very much improvement, that we were asked to then do the electrophysiology. And it was actually marked retinal disease. It wasn't optic nerve at all. So one always has to remember what the tests can tell us and what the tests can't tell us. So electrophysiology will tell us function, neuroradiology will tell us structure. Sometimes they correspond, sometimes they don't. In the comments that we received earlier on, monitoring with VEPs and ganglion cell OCT, sometimes you will get correlation with a pattern ERG, sometimes you won't. You can get completely normal OCTs and completely abnormal function. The two go together. You need structure and function. I think it's erroneous to rely on one. And as an electrophysiologist, structure is fundamentally as important as the electrophysiology.
Thank you very much, Dr. Graham. So to Dr. Alki, in all cases, when do you do this multi-channel examination? Do you do it in all cases of albinism, or would you select some cases? What is the indication to do this kind of investigation? Though, of course, it looks very nice when you showed it. It's not an easy thing to do, and especially when we are not trained. Would you do it in any specific indication in albinism?
Typically now, most new equipment is multi-channel, and in most laboratories, people are able to have more than one channel. So as a standard, even in our pediatric work from newborn, we usually put the 3 channels on. Sometimes if we see some spurious asymmetries, then we'll put the 5 channels on, as suggested by the ISCEV standards. So really in my practice, both in children and adults, we use multi-channel recordings all the time. We very rarely rely on one channel recordings.
That is something which we can all change in our practice. You feel it is no different and not more difficult. Is it more difficult to interpret?
Not really. I think you need to recognize the difference between homonymous asymmetries and going back to Dr. Professor Holder's comment that you need good technicians. So good technicians need to identify, for an example, when a homonymous asymmetry is due to misaligned electrodes or potentially some midline abnormality, if the subject is centrally fixating. So once you exclude all of those potential artifacts that is controlled by the technician, then really identifying if there's a real asymmetry or not, it isn't a big issue. It's very difficult to get across asymmetry artifactually.
Okay, I think one last question to both Dr. Alki as well as Dr. Graham. Where do you place multifocal VEP? Would you want to do it under any circumstances, or do you think it is increasingly becoming difficult, and how do you place it? Dr. Graham first.
I don't place it at all. I don't trust it. If you look at the data that have been published, there are 2 main people who used to do it. That was Don Hood and the Australian group. Don Hood has stopped using them, other than in very selective circumstances. And there are no standardizations. There's poor science. There's very little work on test-retest variability, on different contrast levels. And the 2 groups couldn't even work out where to put the electrodes and how to measure the responses. They're extremely difficult. We were involved partly in a clinical trial once where they gave us a multifocal system, and we could not get reliable data in normals. And I just told them to come and take the machine away. So I have a very poor view of multifocal VEPs, and I don't trust them.
Do you differ, Dr. Alki, or you believe the same?
I don't think we should discard them straight away, but definitely in clinical use, I completely agree with Graham that we're not able to get reliable results in normals. So I think it's one of those things that a lot of manufacturers are offering now with their systems. And I think, maybe in 5-10 years time, with a lot of work, maybe they will be useful. But as a routine, I don't use them in either adult or a pediatric environment.
Okay, thank you so much. Yes, Rashmin, the last word from you.
No, Parveen, have you been doing it? I know you did a lot of work when we got it in SN. Have you continued to work on it, or?
We also have stopped working on it. The newer systems don't come with very great softwares now, because I think increasingly nothing really moved forward, and it started as a research tool, and I think it remains more or less like that. So our experience has also been limited. So with that, I thank you all, Dr. Neha, Dr. Graham, Dr. Alki, Rashmin, Shikha, for joining me here for the first session of the day. And I now over to Dr. Arshi, who is the moderator for the next session, as well along with Dr. Vikas. They'll take us to the next session on the extended role of electrophysiology. Thank you so much for joining us.
Thank you so much, ma'am. Ma'am, am I audible? Can you hear me?
Yes, we can hear you. I will request the speakers and panelists for the previous session, if we can kindly switch off our cameras, that will allow the next group of panelists and speakers to take over. Thank you.
Thank you, ma'am. So we have been listening to wonderful talks since last evening covering various aspects of electrophysiology. And I'm really excited to bring to you this last session of this program, wherein we are talking about the expanded role of electrophysiology. We have just heard about the role of electrophysiology in neuro-ophthalmology, and we are looking forward to hearing some wonderful talks in the areas of vascular retinopathies, autoimmune diseases, and inflammatory diseases. Without further ado, I would first like to invite the panelists for this session. So I would first like to invite Dr. Vishali Gupta. She is the Chief of Vitreoretina and Uvea Services at PGI Chandigarh, and she is the current President of the Uveitis Society of India. Welcome, ma'am. Next, I would like to invite Dr. Sudha Ganesh. Ma'am is the Deputy Director of our Department of Uveitis at SN Chennai, and she is the past President of the Uveitis Society of India. I would also like to welcome Dr. Rajini Bhattu, who's a Senior Consultant in the Department of Ophthalmology at Aster CMI Hospital in Bangalore. She's the co-founder and Chief Medical Officer of iSTEM, a company dedicated to retinal stem research. In the session with will be Dr. Vikas, who is Senior Consultant in the Department of Vitreoretina at SN Chennai. And now I would like to invite Dr. Subhadra Jalali for the first talk of the session about ERG in vascular retinopathies. Ma'am holds a position as Director at the Newborn Eye Health Alliance and Director Quality at LVPI. Warm welcome to you, ma'am. We look forward to hearing from you.
Okay, can you see my slides?
Yes, ma'am.
Right. Okay, so good evening, everyone. It's such a great pleasure to be with all of you. And I'm going to just give some insights into the vascular retinopathies and the electrophysiology, and few pearls are in italics on each slide. So some of the conditions where the vascular supply is affected and the ERG shows that up are Ocular-Smith syndrome, retinal vein occlusions, retinal arterial occlusions, diabetic retinopathy. There are also effects which you can study because of the toxicity on the vascular network. I'm not going to go into those details, but yes, we've had patients of quinine toxicity and of snake bite showing very profound electrophysiology changes. So why electrophysiology is so very critical is because of this beautiful dual blood supply, where the outer retina is supplied by the choroidal vessels and the inner retina by the retinal vessels. And we know that the A wave, which will represent the photoreceptor function, would get affected if the outer retinal blood supply is affected, and same way for the inner retina, the B wave will get affected. So these are important things, and of course the flicker implicit time gets prolonged whenever there is an inner retinal ischemia, and same way the oscillatory potentials which come from the inner retina, they are lost when there is ischemia. So always clinical correlation is important, the history is important. As we go down the cases in this presentation, you will see that history and good observation skills along with the electrophysiology makes the day. So here we have, just to show what abnormalities we can see, the normal is here, this is on the old LKC machine. We can see that the flicker ERG, if it is more than 37 milliseconds, then it is affected, that is in our lab, or if the interocular difference is more than 7 milliseconds. So in this patient, you can see that the flicker implicit times are 39 and 41. So both the eyes are showing affection and the oscillatory potentials are quite small. Here we see clinically, although this patient is diabetic, but there is no NPDR changes.
Just a second, Dr. Subhadra, your slides are not moving.
Is it moving now?
Ma'am, I think are you on the presenter mode?
Yeah.
No, Subhadra, it's not on slideshow, at least in my, yeah, now it is.
You can see now?
Yeah.
It's fine now.
And is the slide clearly visible?
Yes, dual blood supply.
Yeah, so we can see the dual blood supply here. And has the slide moved now?
Yes.
Okay, and we can see the slide of the Oculus-Mix syndrome showing the ERG changes. And so I was showing that the flicker ERG for me is the most important one to look for inner retinal ischemia. If the implicit time is more than 37 or the intraocular difference is more than 7 and they're abnormal or absent oscillatory potentials, these are most important. The B by A wave ratio has been given importance, but to me it's the flicker ERG which is the most critical to pick up inner retinal ischemia. And we can see on the image here on the floor screen that there is no NPDR, there are no microenzymes, no hemorrhages, and there are new vessels in one area. This was a patient of Oculus-Mix syndrome. There is no vascular occlusion in this side. The normal is on the right side below. Now, this is a patient who was referred to us for diabetic retinopathy screening before cataract surgery. She had 20/50 vision in both the eyes and nuclear cataract +2. And although she has diabetes, but there were two important points in the fundus which made me think that this is not a simple NPDR. So one was a bird-looking posterior pole. You can see there are hardly any microenzymes or hemorrhages around the fovea or in the nasal part. There's just few hydroxylates in the periphery. And the most important was the sausage-shaped changes in the superior vein. And so we did the electrophysiology to look for ocular ischemia, and you can see that in both the eyes, the oscillatory potentials were absent, the flicker was markedly delayed and abnormal. So we warned the cataract surgeon that this patient has an underlying ocular ischemia, and while you do the cataract surgery, we need to follow this patient very closely for development of rubiosis or any neovascular process. She got 20/25 after cataract surgery, and after 4 weeks, she lands into the emergency with dense fibrin in the AC, and it was misdiagnosed as endophthalmitis. A vitreous biopsy was done, intraocular antibiotics were given. She had dense fibrin and something which looked like a hypopion. But then after 2 days, she developed an intraocular pressure of 40. So she developed a full-blown neovascular glaucoma. At that time, they went back on the notes and saw that we had warned that this patient can get, neovascular glaucoma rubiosis. And then, of course, we treated that neovascular glaucoma. And while we were treating that, the other eye showed rubiosis, the unoperated eye. And that eye, we did panretinal photocoagulation. And following that, she had uneventful cataract surgery and 20/20 vision. So it's very important to clinically suspect these cases, and then you can, prove them with electrophysiology, because the fluorescein may not show you this inner retinal ischemia which is happening because of underlying carotid artery disease. So in retinal vein occlusion, I think Son Singh Hare has beautifully shown us that while there are various, tests that have been shown to differentiate ischemic from non-ischemic, it's the ERG, which is so good. I always use ERG. I never use FFA in my CRBO patients because it's non-invasive. It will detect the inner retinal ischemia. It is not limited by the wide field. It is not limited by media opacity. It's non-invasive. Even patients with so many systemic comorbidities with CRBO, and it's not limited by retinal hemorrhage. So very safely we can do this, and we can predict whether that eye is going to develop rubiosis or NVE or NDA. And you can see here that the fundus photo and the fluorescein may not show you things at the acute phase, but your ERG is showing that there are very good oscillatory potentials. There's a very good A wave and B wave formation. The flicker is not much delayed. And so here, the flicker implicit time was 33 and 27, not 37 or more. So this patient is going to recover very well with anti-VEGFs, and they're not going to develop any ischemic events later. On the other hand, this patient, which has very few hemorrhages, but you can see here that there's a very bad flicker and it's very much delayed, prolonged, 47.6. And this eye, after 3 weeks, developed, rubiosis and went on to have treatment for the neovascular process. So you can see here that here the FFA did not show a marked change. Of course, with the OCT angio, you might see more of ischemia, but here the FFA was not showing too much of ischemia, whereas the oscillatory potential and the flicker were telling us that this eye is going to develop severe ischemia, and later she developed neovascularization. So in the CVO study, because they did not use electrophysiology, there were many patients who were initially labeled as non-ischemic, which converted to ischemic, more than what we find in the routine practice. And the reason for that was that they used only FFA to differentiate ischemic from non-ischemic and did not use ERG. And I think here we have a patient who has bilateral retinal vein occlusion simultaneous, and we can see that the ERG is telling us which eye has better flicker, which eye has better oscillative potentials, and that is going to be a non-ischemic eye, whereas the right eye has very deranged electrophysiology. Now, if in this state you do an FFA, it will not give you much information because the hemorrhages will not allow you to see the capillary non-perfusion, and definitely it will not tell you about the inner retinal ischemia. In retinal artery occlusion, usually we don't use electrophysiology because the cherry red spot and the dramatic onset of vision loss is so classic that you can diagnose acute CRAOs very rapidly with your fundoscopy, and you don't need anything. Even undilated pupil, you can see that they have RFPD and the fundus shows cherry red spot. And same thing in ophthalmic artery occlusion, there will be very severe vision loss, but the electrophysiology can differentiate between these two, where in ophthalmic artery occlusions, both the A and B wave will be absent because both the dual blood supply has been lost. But in retinal artery occlusion, where we do use it, so this is just to demonstrate that in an acute retinal artery occlusion, you will have a negative ERG where you can see that the A wave is there and the B wave does not go above the midline, and the oscillatory potentials are affected. The 30 Hertz and pattern standard flash are, the photopic standard flash are absent. So this is very classic, but you don't do this test in acute retinal artery occlusion. When you have a cherry red spot patient, the first thing you do is go ahead and do his paracensus and take care of his cardiac status. But where we do look at this negative ERG can be so many other conditions. Whereas when there is a retinal artery obstruction which has happened in the past, that is where this test helps us to differentiate. So these patients will usually present with some sort of a disc pallor. So here we have a lady who has come with disc pallor and extensive RP changes, and this she was labeled as healed choroiditis with secondary optic atrophy. But when we asked the history, she told that she has lost vision during her pregnancy. And now, she has some RP changes in the macula, there's some arterial narrowing. But when we did the ERG, it was showing us that there's a gross reduction of the B wave amplitude, which tells us that actually she has had an old retinal artery occlusion in that eye during pregnancy-induced hypertension, and it is not because of retinal dystrophy or retinal degeneration or choroiditis, because in those cases the photoreceptor degeneration leading to consecutive optic atrophy would have shown a very markedly reduced A wave. So these changes which you are seeing in the fundus are because of hypertensive choroidopathy, hypertensive optic neuropathy, and hypertensive retinopathy changes after many years of the event having happened. This is almost 8 years later. So here we have a very nice case where a patient came with disc pallor, 54 years old. He said that he had lost his vision 2 months ago and it has recovered. His vision was very good. It was 20/20, 20/25 in the left eye. And he had little ill-sustained pupil and he was labeled as recovered retrobulbar neuritis. However, when we did the field test, it was showing something which we don't see in resolved retrobulbar neuritis. And this is why the patient is very unhappy with his vision. Whenever there's a patient who has good vision, but patient is unhappy, I think the first test to do is the field test. And that will tell you why the patient is unhappy with his vision. But these fields are not at all suggestive either of non-ischemic anterior optic neuropathy or of resolved optic neuritis. It's too diffuse. And then when we did the electrophysiology, the pattern VP, these are normals on the top and these are of the patient. So in the right eye, he had very good pattern VP. In the left eye, they were not good. So as Graham always has taught us that don't do VP just to evaluate disc pallor. Always do ERG, pattern ERG and flash ERG so that you can know whether that disc pallor is because of an optic nerve dysfunction or a retinal dysfunction. So when we did the electrophysiology, that is the ERG, we found that in the left eye, the A wave was good. The B wave was little delayed and broad as compared to the right eye, but it was still recordable, but it was abnormal. That means that there is some dysfunction of the retina happening. And when we did the oscillatory potentials, they were recordable, but the photopic responses were, quite bad in the left eye as compared to the right eye. And the flicker was markedly delayed. It was markedly delayed and abnormal in that eye, and there was no recordable pattern ERG in the left eye, whereas it was recordable and decent in the right eye. So this told us that, the patient doesn't have an optic nerve dysfunction alone. The optic nerve dysfunction is coming from their retina. And you can see that in the OCT also, the right eye, the foveal contour was good. In the left eye, the foveal contour is abnormal, but rest of the retina, inner retina, structurally is normal, whereas as we saw, the function was pretty abnormal. So we come back to what Graham said, the structure and the function, both important. And if you see this patient, this is another patient's fundus, something called as transient retinal artery occlusion. So we've all seen, old complete retinal artery occlusion with cherry red spot. But if the obstruction goes away within less than 4 hours, then the patient will not have cherry red spot after a few days or even few hours. Even from morning till evening, the retina can just look normal because all this cloudy swelling of the retina goes away. But the function doesn't go away, the structure shows. So you will not see the classic negative ERG in these eyes because the function has recovered partly. And what you will see is what I have shown, that there is an abnormal fields, there's an abnormal pattern ERG, and there's abnormal flicker ERG, which is telling us that there is an inner retinal ischemia which has happened because of that transient artery occlusion. Patients, of course, need complete evaluation of their cardiovascular system. So this is just to show you how we could come up to the diagnosis that this pallor which we are seeing is actually because of a transient retinal artery occlusion which patient had got, and then it had recovered on its own because the embolus can travel downstream. So I think the pearls that I want to share with you is that in vision loss of unknown origin, the combination of tests is important to know which level of the visual system is affected, and keep in mind that vascular systems can reflect their function in the electrophysiology. And the flash ERG is an extremely valuable, non-invasive, highly sensitive test in conditions that affect the inner retina. And if you want to know more, I invite you tomorrow evening at 4 p.m. Indian Standard Time to our seminar on best of inherited retinal dystrophies, where we'll be discussing the clinical aspects of how to use these tests and how to use additional tests and what to tell the patients and how to evaluate and treat them when they come to your clinic. So thank you. You can register at cme@lvpi.org if you want to attend the seminar tomorrow evening. Dhanyavadalu. Thank you.
Thank you so much, ma'am, for that wonderfully illuminating talk. And now I would like to invite Dr. Graham Holder for the next talk on electrophysiology in inflammatory and autoimmune diseases. And now I would like to invite Dr. Naheed Khan for the last talk of this session on essential clinical and electrophysiological considerations for establishing therapeutic interventions in IRDs. Dr. Khan is an associate professor and director of the Visual Diagnostic Lab at the University of Michigan, the Kellogg Eye Center. Warm welcome to you, ma'am.
Good evening. I would like to first thank Dr. Sen and all the organizers for inviting me. The second thing I would like to say is that my presentation is going to be very different from all the presentations we've had this morning. I'm going to basically discuss the essential clinical considerations for establishing therapeutic interventions in inherited retinal diseases. So IRDs are blinding genetic disorders that have been untreatable until recently. They're caused by mutations in genes that are responsible for cell death. And the disease origin is in the RP, photoreceptor cells, or bipolar cells. Depending on the type of IRD, patients lose visual acuity, night vision, peripheral vision, and central vision. The treatment success in IRD due to mutations in the P65 gene has triggered many clinical trials in the past decade. Since the discovery of the first retinal disease gene more than 30 years ago, 280 genes have been identified in several forms of retinal degenerations. So IRDs are heterogeneous with varying forms of visual dysfunction. I'm using this figure from Jacobson and Sidesian, where they nicely describe the stages of degeneration in an IRD, and there are some treatment options that are available for each of these stages. So in stage 1, photoreceptors are still present and viable, so gene therapy is the option. In stage 2, there's degeneration of photoreceptors, so one would want to halt or slow progression by providing a neuroprotective environment. In stage 3, with loss of outer retina, regenerative therapies to replace photoreceptors is the treatment. And of course, in stage 4, with advanced degeneration where outer retina is lost, retinal implants or optogenetics can be used. So the clinical trials landscape is complex and challenging with many components. These are not necessarily shown in the order, done in the order that I'm showing here, but the evaluation of the potential benefit of novel therapeutic interventions involves assessing specific outcomes and proof of concept gene therapy studies. This will also involve examining disease mechanisms, the natural history and disease models of animals, which are naturally occurring and also genetically engineered lab animals. The natural history diseases studies and disease characterization have to be done to understand genotype-phenotype correlations. And sorry, I'm having a problem with my mouse here. Genetic heterogeneity and diverse phenotypes pose challenges to understanding disease pathology, to predict treatment benefit, and selecting outcome measures and endpoints to evaluate treatment safety or efficacy. So outcome measures must have high reproducibility and reliability, and we should evaluate variability, inter-eye, intersession, and intra-session. The other last thing is to also quantify structure-function relationships and to evaluate the integrity of the retinal layers. So there are multiple interventions going on. There are more than 30 current or completed gene therapy trials, clinical trials for IRDs using recombinant viruses. But as you can see from this table from NIH.gov, there are several interventions targeting the same IRD. Here is a list of the assessments for visual and retinal function and structure. There are a lot of different types of tests that are used in different clinical trials, but the choice of test or combination of tests depends upon the disease phenotype. So first, this is an example of a natural history study which was conducted by Spark Therapeutics in order to understand the natural history visual parameters over time in patients with RP65 gene mutations. So they included data from charts of 70 patients from 7 internationally recognized IRD referral centers. The top panel shows visual acuity. Most patients have legal blindness from a very early age, and by the 4th decade, they have lost the ability to perceive hand motion. The lower panel shows the Goldman visual field areas. 50% of the visual field is lost for the 2nd decade of life, and legal blindness status by the end of the 2nd decade by the visual field. Now I will talk about some of the outcome measures. We don't have time to do too much detail, but I just want to list the ones that are most commonly used. The first is static perimetry, which is very good for defining small sensitivity levels and to detect sensitivity gradients. But a better interpretation of, to enhance interpretation of static perimetry, the Hill of Vision analysis, which was developed by Dr. Richard Welleber, is very useful, and it shows the topographic modeling of visual field sensitivity data. The software VFMA generates a 3D Hill of Vision model with ISO sensitivity contours, which contours at 2 dB intervals, like here. And it allows the visualization of the areas of sensitivity loss from various different angles to give it a better view, and gives a quantification of the loss. The next test is fundus guided microperimetry. Here I'm showing the examples from the MAIA instrument, which is macular integrity assessment. It is recorded with, it's a visual field test that measures retinal sensitivity. It is recorded with simultaneous fundus tracking and allows for accurate quantification of visual sensitivity at specific points on the retina. So the output from the MAIA shows the average threshold for this exam on the gray bar, and the lower bar shows the histogram of threshold frequencies compared to the reference database, which is a green region, and the patient's data is shown on the shown right here with the gray bars, which has very low sensitivity. So measurement of rod-mediated function in IRD's treatment trials is a valuable outcome measure. There are 3 different types of two-color perimeters. I'm showing here the modified Humphrey field analyzer, which was developed by Jacobson and his team back in 1986. So the test is conducted under dark adapted conditions. It is used to assess dark adapted visual field abnormalities in photoreceptor function. It presents 2 different color stimuli, blue at 500 nanometers and red at 650 nanometers. The blue stimulus is used first to record rod-mediated function, and then followed by the red. And you can see the outputs for 2 RADP patients on the top panel. The patient has mostly rod-mediated function thresholds, while the patient in the lower panel has both rod and some cone mediated function in the outer periphery. The ERG, of course, is another outcome measure, but it's not used very much. This is just an example of a rod cone dystrophy type of ERG with highly reduced rod-mediated responses. Cone-mediated responses may be still residual and very low, and delayed responses. By the end, in the advanced stages of the disease, these will also become non-detectable. Patients have highly constricted visual fields. In the cone and cone rod dystrophies, the rod-mediated ERGs may be subnormal or nearly normal, but the photopic ERG will be very reduced and also non-detectable. These patients have normal peripheral vision, but their central vision is highly compromised with central scotomas, and they're mostly legally blind. So gene therapy shows restoration of ERG responses in animal models, which is very useful for translation research to study the drugs, the interventions in animals before moving on to patients. The RPGR knockout mouse gene therapy in this model showed improvement in the dark adapted ERG as well as in the light adapted ERG when compared to vehicle. The achromatopsia CNGB3 dog has normal rod-mediated function, but undetectable cone responses. After treatment, I'm trying to move the panel here. Okay, after treatment with gene therapy, the cone responses were completely restored. In human interventions, no one has demonstrated ERG, full-field ERG improvement yet. It is used to demonstrate safety and to monitor the durability of the intervention. If the ERG is undetectable at the screening visit, then it is not repeated at follow-up visit. In some trials we are doing, it is just done at the first visit and then at the last visit. So, but these tests, the next test, full field stimulus threshold or FST, is a very useful test and it seems to be used in many trials. It is a psychophysical test that provides a measure of light sensitivity across the entire visual field. So in the test that we described before, perimetry and microperimetry tests, the patient should have some ability to fixate. However, severely affected RP patients lack that ability to fixate, and they have involuntary eye movements, so it is difficult to determine the accurate retinal location that is perceiving the light stimuli. So the FST was developed to quantify sensitivity by stimulating the entire visual field using the LED-based light stimulator, the Diagnosys color dome. This was first done by Roman et al. For the very low vision patients. However, since then, this test has been used for in many trials, even with moderate vision loss, patients having moderate vision loss. So it detects the lowest intensity of light that is perceived by a subject under dark adapted conditions. The patient is presented short duration 4 millisecond flashes, and forced choice procedure is used where the subject uses a 2-button box and an audible cue to indicate if the flash was perceived by pushing the green button or if the flash was not perceived by using the red button. And the output is given as a single threshold value as the mean of each trial. Several trials are done and basically the software plots the percent detection as a function of log luminance. So all the points here indicate that the patient was able to perceive those points at different intensities, and here they did not perceive, and anything in between gives a probability about 50% chance, or in this case 80% chance that they saw. So the lower the luminance, the higher the sensitivity and the lower the threshold. And with increasing if the patient is using higher in luminance, then the threshold is high, sensitivity is low. One thing as a user is to see that these graphs that are output are almost vertical, and this is a very good quality result. If the graph is curved, or in this case, which is a really bad response from a 5-year-old who has no interest in doing the test, this type of result is not interpretable. So the FST can also be used to understand cone-mediated and rod-mediated vision by changing the wavelength of light. As an example, in this study of the rate of progression of USH2A-related retinal degeneration, the FST was used, and you can see that in some patients with advanced disease, they only have barely cone-mediated responses, and these are also, they're using very high luminance, whereas the rod-mediated patients with rod function intact can show lower thresholds. Now, finally, imaging measures are also important. Most of these are done by in autofluorescence. The hypofluorescent ring is monitored, and the easy width is used on the OCT. There are many variations of how these are evaluated, and many software have been developed by various different investigators. Now we will talk about multi-luminance or mobility testing. So the clinical tests of visual function generate precise metrics to evaluate treatment, treatment efficacy. So the outcome measures that are not meaningful to the patients, like showing a small increase in the ERG or a small increase in the microperimetry, doesn't mean very much to the patient. So the outcome measures that are meaningful to the patient has to be developed, which define visual performance under real-world conditions, such as patient-reported outcomes and performance-based tests. Another example is vision-guided mobility, which uses mobility performance tasks to show a subject's ability to use sight for navigation in a safe and efficient manner, and often under different lighting conditions. So I'm going to talk to you about two different types of MLMTs. The first one is the Pedestrian Accessibility Movement Environment Laboratory, PAMELA, which is a setup at a facility near London in UK. It is a life-size pedestrian walkway, and the illumination is controlled by LED panels. This particular MLNT provides a very wide dynamic range of illumination from 0.2 lux, which is almost like a moonless night, to 15,000 lux, which is bright sunlight, but not direct sunlight. The panels in this walkway can be moved, and they are always changed to change the configuration so that the patient does not memorize the path. This is a schematic of the path where they first go through the maze and then back under various luminance conditions. And they also have a straight line path with obstacles on the way, where they have to step over a block or to move around a cone. So this slide shows all the different lighting conditions in the Pamela. For patients with poor night vision, the lower lighting conditions are used anywhere between from 1 lux all the way to 256 lux. I believe for our setting we use 1 lux, 16 lux, 64 lux, and then 256 lux. The bright ones lighting is used for patients with achromatopsia who experience photophobia. The next test is the MLMT, which was used by Spark Therapeutics for the voretigene gene therapy. They used the MLMT as their novel primary endpoint. So this is a much smaller MLMT, measuring only 2 meters by 3.6 millimeters. It is a white cloth that has 30 centimeter squares. It has these black arrows which the patient has to follow, and the patient has to avoid the obstacles which are probably next to each of the squares, and also negotiate any obstacles which are along the path. There can be, this is a raised block and there's a step and they have to avoid this hole on the right. And I mean, these are not dangerous conditions. It's just the path is recorded to see if they have any errors. And finally, they have to go through the door. So in all of these tests, the number of errors, scoring is done by measuring the number of errors, that is bumping into objects, the walking speed, and how they negotiate the MLMT. And again, this was done under 3 different lighting conditions. This tells you that 1 lux is a moonless summer night, 50 lux is about like an outdoor train station, and 256 lux is more like an office setup. But some of this MLMT has some ceiling effects because all of the unaffected subjects were of course able to pass the test, but some affected subjects also were able to pass when they should not have. Now, clinically meaningful endpoint. So outcome measures are the tests that are done on these patients, and certain parameters are measured from the outcome measures. An endpoint is a particular parameter that is used to define the success of the intervention. For example, they can use best corrected visual acuity, or the B wave amplitude of the ERG, or things like that. So these are the endpoints that are acceptable to the Food and Drug Administration and the European Medicines Agency. Best corrected distance visual acuity, visual field sensitivity using perimetry and the Hill of Vision analysis, retinal sensitivity measured by the FST, and the multi-luminance mobility tests. Now, MLMT is not a feasible test in real-world follow-up because it's difficult to set up in every clinical center. So a study was done which showed very high correlation between the FST and the scores from the MLMT. Thus, the FST is a reliable surrogate marker for the MLMT. So it is very important. So it is very important, I think, if you're doing clinical trials, to have the FST available. So I just want to leave you with 3 following slides. This describes a typical gene therapy center, which we have at Kellogg Eye Center. And there are other centers, of course, similar to this. The first component of the gene therapy center is the clinical one, where we do diagnostic evaluations. Genetic counselors will record the family history and pedigree and come up with the mode of inheritance of the disease. The clinical evaluation is done by the physician, and we come up with a clinical diagnosis which helps to direct genotyping. You can have a genotyping lab in the center, but now there are many other labs elsewhere. But you can also have on the side animal models, disease characterization and natural history, so that you can have these setups for recording electrophysiology in animals and imaging. I have done hundreds and hundreds of ERGs on animals to record characterized diseases with different IRDs and therapeutic interventions. So animal models are very important because that is where we test all of the disease, all of the potential interventions. Some scientists also can be developing vectors. So we do have some scientists who have developed vectors for the RDH12 gene now. Then we also need to have a study clinical trial center, which has study coordinators who arrange for all of the visits. They do all the outcome measures before the trial starts, and also follow up with the multiple visits which the patients have to make during the course of the study. Now, the mode of inheritance, which is important to know so that you know which gene is being affected. But sometimes the pedigree alone is not helpful. Here it was difficult to determine if this was an autosomal dominant or an X-linked type of inheritance. So when genetic testing was done, it was found that this patient had the RP2 mutation, which is consistent with X-linked RP. And finally, I have been collaborating with Dr. Pankaja Doble for the last 5-6 years, helping her to set up the ERG lab and also to start working with IRDs and helping her to diagnose. So one of the things I told her was you need to let others know that you have all these patients. So we did a study with we took all of our patients based only on clinical diagnosis. These are not genotype patients. And we just wanted to present a poster at ARBO 2020, but that was not meant to be. I wanted her to go and meet other people who are doing clinical trials and probably also some sponsors. So if you want to be involved in clinical trials, you have to make known what you have. And in India, there are so many patients that it's like a gold mine of having some, because the patient populations are really very small in these diseases. And so there are clinical trials can be very expensive, running into millions of dollars. So these are financed by industry. The challenges that we face in the design and to study our design and ethical concerns because of the small patient populations. So you may have like so many RP patients, but you have to find out which gene you're going to be treating, and then the inclusion-exclusion criteria will then determine how many patients can be included in the study. So that really trickles down the numbers very, very much. And the patients are young because younger patients can show better improvement. And the design and analysis of outcome measures and definition of endpoints also poses a challenge. If you want to get started, you can develop your own IRD patient registry based on genotype and phenotype by partnering with other centers. There is also the Retina tracker patient registry, which was developed by the Foundation Fighting Blindness, and it is globally accessible. So basically, partnership and team approach is very important in getting into clinical trials. I'd like to thank you for your attention.
Thank you, Dr. Naheed. We really love to talk about all these novel tests and how to set up our centers for gene therapy in patients with IRGs. I would now like to invite all the panelists and the speakers and open this forum for discussion now.
So I'll begin the panel discussion. We're actually 5 minutes past the closing time actually. So my question is for Dr. Jalali. Do all your patients of ocular ischemic syndrome undergo electrophysiological testing? If yes, at what time point in their workup do you decide to do the testing?
Yeah. All my patients where I'm suspecting ocular ischemic syndrome, they undergo electrophysiology. They may or may not undergo fluorescein or other tests. The reason for this is because if you rely only on the carotid Doppler imaging, a lot of patients in India have intracranial carotid artery disease, which will not be picked up by your extracranial Doppler scan, which is often done in our imaging centers. They do only extracranial. There are very few people who do transcranial Doppler for the internal carotid artery. And this I'm speaking because my husband is a stroke specialist for many, many years. So Indians have a lot of intracranial diseases, and that can be picked up either by transcranial Doppler or by a carotid angiography. Now, carotid angiography is an invasive test. We don't do it. But your electrophysiology guides you that there is an ocular ischemic syndrome, whether your carotid Doppler shows it or not. Sometimes if you have enhanced color Doppler of the orbit, that can also pick up the disease. But again, that is not freely available to everybody to do color Doppler imaging of the ophthalmic artery. So because this picks up a lot of disease, you can actually follow up these patients very closely for development of rubiosis, for development of NVA, and then do prophylactic laser, and then everything goes away. And in fact, as I showed in that patient, if you do cataract surgery in a patient who has an underlying ocular ischemia, the patient will return with very severe inflammatory response and neovascular glaucoma. And we've had many patients like that. So I always like to do electrophysiology because it is a very robust test. It has very high sensitivity for inner retinal ischemia. It doesn't lie. The difference between a normal and an affected eye is so huge, as I showed in my presentation. And I had discussed this in detail with Mary Johnson, who has done a lot of work on electrophysiology in ischemic eyes with CRVOs. And we agreed that electrophysiology is a really good test. The flicker implicit time, the oscillatory potentials, they really show up very well in eyes with ocular ischemia.
And do you ever repeat it in follow-up?
If it comes as non-ischemic, for example, if I have an acute retinal vein occlusion, because few retinal vein occlusions, they can be evolving from non-ischemic to ischemic. So if I have a patient who has come within a month of the symptoms and I'm suspecting a non-ischemic and I do the test and it shows non-ischemic, then I might repeat it, especially if the patient is not resolving or it shows more hemorrhages after some time or the vision goes down. That's one. I have also seen, patients where the electrophysiology improved after anti-VEGF. If you had given it very early, whether it was non-ischemic or borderline ischemic, and you gave an anti-VEGF very immediately after the onset of the attack and didn't wait for 2-3 months, which used to be the practice before. So even when the vision is good, if there's an edema or there's an ischemia on the ERG, you give the anti-VEGF, actually the ERG reverses. So you can see that the function has reversed. It's really, it shows up very well. Yeah, so I repeat it if it is non-ischemic. If it's already ischemic, then I may not repeat unless I'm thinking that it has shown a dramatic response to anti-VEGF, then I might repeat it just to see whether the function also returned.
So we have the former president and the present president of USI as panelists. And Dr. Holder's talk was, I think, very, very interesting. So Dr. Gupta and Dr. Ganesh, have you used ERG to monitor therapeutic response in your patients using ERG as a electrophysiology as a tool? Dr. Gupta first.
You want to ask me first?
Yes,
Every time I listen to Graham, I am motivated to quit doing retina surgery and study electrophysiology. But unfortunately, the moment I go to real world, honestly, I don't understand it that well, like Subhadra and Graham and all these people. So when I look at the waves, I don't make out what's happening. So I look at OCT, it shows me a dramatic reduction. I look at autofluorescence, and I feel very happy about it. So to be very honest with you, just now when Graham was talking, I was messaging my colleague, Simar, who's now doing the dystrophies. I said, we have to get Graham to our institute when things are a bit better. So we get him, he teaches us, and then you ask me this question, because from now onwards, I'm going to use it. But Graham, I have a question for you. Can I ask just one last question? I know you are running late. Graham, we are seeing these patients with photoreceptoritis post-COVID, and I'm personally following them up very closely. So do you think when I do electrophysiology, the post-COVID or post-COVID vaccination photoreceptoritis would be different from an underlying, say, subclinical dystrophy or whatever?
That's a very difficult question because we don't understand currently the pathophysiology. It's certainly not going to have the same time scale as an inherited dystrophy. It's not going to be a sort of programmed up apoptosis. We've seen 1 or 2 patients in Singapore where they've been referred for suspected problems. One of the things that has also come about certainly in 1 patient was that they were asymmetrical. And that again would be unlike an inherited dystrophy. I mean, you can get inherited disease which is asymmetrical, but it's not the first thought that you have. But until we understand what the pathophysiology is, because one of the things about electrophysiology is it's not just something that you look at and say it's normal or abnormal. You have to look at the origins of the signals in terms of cellular structures, and then you have to relate those findings to the underlying pathophysiology. So without the knowledge of the pathophysiology, the electrophysiology may help us understand the pathophysiology. But at the moment, I'm not familiar with anybody that's given me convincing evidence of what that is.
Thank you. I think I'll need your help when we follow those patients. I'll get back to you. Thank you.
I'd be very happy.
Dr. Ganesh, your take on?
Yeah. In my uveitis practice, I find a lot of difficulty in patients with white dot syndromes. When the white dot syndromes do have a clinical presentation, when I'm able to pick up the clinical features on the fundus examination, I have no problem. But there are some patients who keep complaining of scotomas and photopsias, and they don't see and I don't see as well. So in these cases, I rely a lot on ERGs that we do, the full-field ERGs, and look at the A and the B waves, and look at the flicker, cone flicker. And sometimes probably the EOG may help us in diagnosis of these cases, especially the azure that we are looking at and the autoimmune retinopathies. The autoimmune retinopathies do have a negative waveform, whereas in azure we find the amplitudes are reduced, and we do follow them up with therapy, and we look at the visual fields and the ERGs. We do the full field ERG and sometimes the multifocal ERG as well, and look at whether the patterns are changing with therapy to give us a guide as to when to stop the therapy. But in most of the cases that we find constricted fields, enlarged blind spots, scotomas, with the ERG changes persisting, especially in autoimmune retinopathies, which require sometimes immunosuppressive therapy to control the disease. So where multimodal imaging doesn't give me an answer, where I don't have anything to look at, then ERG is my go-to.
And also, I think in addition to what Dr. Sudha is beautifully put, sometimes these patients with dystrophies have inflammation, and many a times they're diagnosed as intermediate uveitis. And, you know, it's very useful for those patients just to say the inflammation is epiphenomena of dystrophy and not vice versa. Sometimes, like Graham was showing, that you could have spontaneously reattached retina, or you could have post-trauma, which is a pseudo kind of. Yeah.
And I
If
have
I
one
can
question.
comment on that, that's actually very, very appropriate. I do a clinic, at least pre-COVID, with Adrian Coe, who you probably know, and we were doing the clinics together, and many of them were in inherited diseases. And Adrian's question was always asking about whether they feel as if they're getting smoky vision. And these are people who develop changes in their visual perception, which are not related to the underlying retinal degeneration. And many of them have cells, if you look very deep, they're very deep cells, and they respond to treatment. And they are the only ones that he looks for anti-retinal antibodies in. And if the antibodies come back positive, then the patients get treated, depending on which Adrian feels appropriate. And then we have actually seen resolution of the antibodies. So yes, you can undoubtedly get an autoimmune response, but it's not causative, but it can be treated. And if the patient has a change in their symptoms, particularly if it varies from day to day, then that's something you want to perhaps consider.
Yes.
Can I ask a question?
Yes, ma'am.
Just yeah. If you remember, Dr. Vikas, we have a patient between the two of us where we diagnosed it to be query primary intraocular lymphoma versus a white dot syndrome. I would like to ask Dr. Graham whether he has any ideas on ERG or electrophysiology, which may help us to differentiate the two.
It's very difficult to generalize when what's needed are specifics. We'd have to look at the clinical presentation, the nature of the electrophysiology, but lymphoma tends to be pretty bad news.
Dhanashree, do you have any other questions for the UVA panelists?
Yes, I would definitely like to take the opinion of Dr. Vaishali and Dr. Sudha. If they see a role of electrophysiology, including both ERG and VEP, probably as a baseline investigation in uveitis patients, especially considering the Indian setup, wherein affordability is also a big issue for many patients. So should we rely on electrophysiology from the beginning and then follow it up? Or do we just take it as it goes to see whether, as probably as a guide to treatment response?
I think, Dhanashree, for something which is very grossly obvious to me, like toxo or TB or something, I would not really do ERG because the logistics in my high volume clinic will not allow me to base my decision either to initiate the therapy, maybe monitoring, yes, but I cannot wait for ERG results to come because I know they will not get a date as in when I require. But for the complex patients, like Dr. Sudha mentioned, mutes, autoimmune retinopathy, are where I don't understand what's going on. Of course, ERG is a very, very important part of workup, atypical ones.
Dr. Graham, one question for you, because as we discussed in detail about white dots and Azure and AIR, I would also like you to just give us a few pointers in the end, if you could, regarding the role of electrophysiology in uveitis patients wherein there is VESETs or VKH. Should we do pattern ERG with VEPs right from the beginning of treatment, or even as an aid to diagnosis, probably if there is optic nerve or CNS involvement?
It's a good question, and I don't have a clear answer. After lots of discussion with the people here in Singapore, particularly Rupesh Agarwal, what we've decided to do is try and get some VKH patients and see if the same applies. He is of the view that electrophysiology can perhaps be used, because he worked with Carlos Pavesio at Moorfields, can perhaps be used in the VKH patients in the same way that it's used at Moorfields with the birdshot patients, possibly to predict flare-ups. But I don't know of any evidence to that at the moment, but it's something that we want to look at. In terms of the white dot syndromes, because the white dots may or may not be there when you see the patient. They may have been there. Depends on how quickly they come to the clinic. A lot depends on I think, whether the patient has got positive phenomena. If the patient has got positive phenomena, then you need to treat it seriously because it could reflect possibly even life-threatening disease. And they need full workup. Any patient who's got suspicion of autoimmune retinopathy, I think needs a full systemic workup. Just in case it's malignancy and paraneoplastic.
So we'll move on to the last talk by Dr. Nahid Khan. Dr. Khan, your talk was excellent, very, very illuminating, especially about the MLMTs that you talked about. If we are to do one test post gene therapy, what would that test be?
I think most of the clinical trials results that are being shown would be the microperimetry. The Maya is supposed to be much easier to use than the NIDEC, and it's widely available. And the Maya also has the scotopic version, so you can also do the rod cone dark adapted responses. So that test is always shown as the one which shows changes.
Dr. Bhattu is also there in the panelists. Your take on the current status of clinical trials in India?
You're muted.
No, we can't hear you.
Ouch. Okay. That's bad. Now?
Yes.
Okay, good. I think my volume was rather low. The first of all, Dr. Nahid, I think that was a very, very good talk. Thank you. I think we are Luxturna has not yet been launched in India because that's the only US FDA approved gene therapy treatment that we can talk about. But I think we have a lot of work to do before we are ready for a clinical trial to happen in India. And we have some of the people representing institutes who are sitting here. So clearly we have because when you look at the outcome measures, it's while because ask for one, there is a whole list of things that we have to be ready with before we can actually have a clinical trial running in any major center. So while you mentioned, yes, we have a very large number of patients with retinal dystrophies. Our biggest bottleneck is still the fact that we are not able to genotype a whole lot of them simply because of cost factors. There's no insurance that covers them. And therefore, while we have a huge number of phenotype patients, we're really not able to have a good genotype. While I have a question, I think that's for both Dr. Graham and Dr. Nahid. While we're talking about FST as one of probably the most important electrophysiological test that is needs to be done, it's still a functional test, isn't it?
Yes,
I mean,
it's a
subjective test.
Yes.
So would any form of pattern ERG be possible? Because see, when the increment of visual improvement is so small,
yeah,
how reliable would something that's a completely subjective test be? In fact, for that matter, even microperimetry, I have used microperimetry a lot, but it's an extremely good test. It's still a very subjective test.
Yes. So the requirements are very rigorous. For example, if you're doing, like the other day, we had a patient doing the Maya microperimetry.
Yeah.
So when they have to repeat the test 2 times, and if the difference is more than half a decibel, that is very, very strict. If the average is more than half decibel, then they have to repeat the test until they can get the same result. The same thing with Luxturna therapy with the FST responses. It is very, very rigorous. They have to keep on doing multiple trials until the average threshold is within maybe 3 dB or 6 dB. So each trial has its own recommendations. So yes, these are highly. They can be subjective, but they also do the measurements in a very strict manner. The thing is with ERG. I don't know why nobody seems to be able to answer this, but in animal models, you clearly see a good improvement, but in humans, you don't. Maybe because the eye is larger or the area, the bleb size of the subretinal injections is much smaller, so the ERG cannot pick big changes. Just like in a macular dystrophy, where the central retina is reduced, the ERG can be normal, right?
Yeah.
Because, so if you improve just a small area and the other, and vice versa, looking at it, it's not going to show very much. But we do have some trials that we are doing through MIRA GTX, where we have to do the multifocal ERG, the pattern ERG, and the full-field ERG. We don't know the results of those yet. The other trials do not use, they just use the full-field ERG just to monitor durability. So we have to do it very carefully because the responses are so small. So I'm very strict about how it is done. Reject all eye movements and everything, and gather a lot of trials, sweeps. But I have noticed, this is just an anecdotal observation, but I noticed that some of these patients will have residual cone responses. So you can get the cone flash and the flicker ERG, although the rod responses will be highly reduced or non-detectable. And then when we do at baseline and when we did the subretinal injections of therapy, when we followed with the ERG, I saw a change in latency. It increased. So it could be something in the subretinal space which is causing that latency. And then 6 months after that, it all normalized. But they come only every 6 months, so I don't know what happened, at what point it gets normalized. But that is just one of the changes. But I don't see any improvement in the treated eye and the control eye. But what we see is like it's stable.
Okay.
Which is also,
can I ask one question?
Degeneration going on at that time, but this is a very short period, like it's just 1 or 2 years. You have to follow them for 5, 6 years. So we do also have long-term follow-up for some of these trials.
Can I make a comment there, please?
Please, yeah.
It depends on which trial you're looking at and the purpose of the trial. Because I was involved in the very first RPE65 trial. The ERG there was necessary because they wouldn't let us move ahead until we demonstrated that the very, very small ERG, which was present in the adults who we had to test for safety reasons, was not destroyed by the procedure. So from a safety point of view, it was essential. But I was then involved with the choroideremia trial. And of course, choroideremia is a different issue. You're not looking to restore or replace, you're trying to preserve what's left. Because in the choroideremia, as you know, you've got central function left. And one of the criteria for trial entry with Rob McLaren's group was the fact that the patient had normal visual acuity. And in one of the patients that we published in the first New England Journal paper, the untreated eye deteriorated and lost its pattern ERG, but the pattern ERG actually showed improvement in the treated eye. Wasn't expected, but that's what happened. So you can occasionally see electrophysiological improvement, but only if you're looking at something that's a very small focal area. So if you're looking at a macula, you're not going to pick anything up at all in a full-field ERG.
Yeah.
As we've already said. And when you're looking at a disease such as the global retinal degeneration, there's no sensitivity that's going to be available to the ERG because of basic inherent noise. You have to rely on psychophysics. I mean, the one patient, when we did the very first RPE65, he picked it up because he could walk through the maze better. He was really, really pleased, but we didn't find any improvement electrophysiologically. In terms of the animal versus human, I just don't think we get enough in the humans. We can't. The animals you can put lots in, and then you can perhaps see it, but it's all been very disappointing. That there hasn't been, I mean, I was present at the ARVO meeting where Jean Bennett showed the very first time, and everybody threw their hats up in the air. It was amazing. But we just can't see it in the humans.
Thank you all. I think we should wrap up now. It's 8:30. We are 30 minutes past the time. I know Dr. Subhadra had a question, but ma'am, you have time tomorrow in your own meeting.
Yes.
Oh, sorry. I'm sorry, Subhadra.
No issues. We'll discuss more tomorrow.
Yes. So we'll continue with the discussion tomorrow. And thank you to all the speakers. Archie, and all the panelists. Thank you very much.
Thank you. Thank you.
Thanks, and that was an amazing
Good night
session.
or good morning, depending on where you are.
Thank you.
Thank you, Vikas. Thank you, Dr. Graham, Dr. Subhadra, for an excellent session. And I think with that, we come to the end. I would like Mr. Rachit to come up with a vote of thanks.
Hi, can you hear me?
Yes, we can.
Yes. Great. So I'm going to try and make this really quick because I know it's late, at least for those of us here in India. It's almost 8:30 on a Saturday night, so I'm sure people have plans. But good evening, everyone. And unfortunately, we have to, come to the end of this webinar. I'm sure if we had a little more time, people would have appreciated it. But we have to set time limits on these things. But it's been a wonderful and immersive event spread over the last 2 days. 5 hours of clinical presentations and demonstrations by some of the best minds in the field of electrophysiology, sharing their clinical experiences in the field. And I have the task of proposing a vote of thanks to acknowledge the efforts that have been put in by several people in making this event happen. At the outset, let me thank Dr. Girish Rao, President of Shankar Nethralaya, for his support and encouragement in setting up this educational session. I have to thank Dr. Parveen Sen, who is the architect of this webinar, and her team, who have spent a lot of time and effort in shaping this event. Dr. Sen is seriously committed to electrophysiology, and I have no doubt that you have seen how meticulously this program has been scheduled. Thank you, madam. Both Dr. Sen and Jeff Farmer, who is CEO of Diagnosys, they have labored tirelessly and used their connections in putting together a fantastic program with a group of eminent clinicians and speakers, both national and international. Ms. Ramya and her colleagues, Vikram, Nagappan, and Indu from the Electrophysiology Department of SN had put up a great video presentation and talk on the technical aspects of performing tests. So thanks to them too. I'd like to acknowledge the participation of the panelists and moderators who have stood by and assisted in the Q&A sessions and created an atmosphere for scientific discussions. I'm sorry that I haven't mentioned everyone by name, but let me thank our speakers for the last 2 days for their contribution to the cause of clinical education and in participating in this webinar. So Dr. Parveen Sen, Dr. Rupa, Dr. Tapas, Dr. Subhadra Jalali, Dr. Neha Goyal, Dr. Tony Robson, Professor Graham Holder, Dr. Omar Mahroo, Dr. Stuart Coupland, Dr. Suresh Vishwanathan, Dr. Nahid Khan, and Dr. Alki Leasis. I would be remiss if I did not mention the tremendous support and work put in by Jeff Farmer, both as a speaker and organizer of this webinar. Diagnosys is an extremely committed electrophysiology company and has always been in the forefront of supporting excellence in clinical electrophysiology. They manufacture some of the finest electrophysiology equipment used by renowned institutions all over the world. And I am glad to say that these fine machines are already in use in several institutions in India. And as a part of BioMedix, who are their associates in India, it is my privilege to be a part of this event. Finally, tirelessly working behind the scenes, sending you all communications and reminders for the event, Natalie Duran of Diagnosys. She has managed the IT part of the program very efficiently. So thank you, Natalie, for your contribution, which was invaluable. So on behalf of BioMedix, I would like to say once again, thank you to all of you for making this event a tremendous success. Thank you. Dr. Sen.
Thanks for putting it all so well and so beautifully together, because without all the people that you've mentioned, it wouldn't have been possible. Electrophysiology is a very difficult and a dry subject. Not many people are very passionate about it, but today I've found it very heartening to know that so many of people registered, and we had more than 250 people logged in on both the days. And I think electrophysiology is in good hands. And I think Dr. Nahid's last talk was most appropriate because it leads the path for the future. And with gene therapy coming in, electrophysiology is going to become even more relevant, is what I think. Thank you once again, all of you, for being here with us for the last 2 days. It's been a great learning experience for me. Thank you. And have a good night. I think Dr. Graham is past his any Saturday night plans also. Okay, bye-bye. Thank you.